and get all the medical services at one spot, at one place, and they will be referred to other social services whenever needed. But we also need to understand that integration is not just about the comprehensiveness of providing care, but also this integration needs to take into account the needs or requirements of a patient, because more often the world is saying that in the issues of adherence for patients who live with HIV, AIDS, the key role is still played by mental health issue. And we face the combination of substance use disorders and integration of this care into the pathway of patients or clients with SUDs. And the issues of a veterans' care and support shall be taken into account at every facility, at every spot of healthcare provision. And the key area for each and every one of us shall be the following. It's not possible to treat a patient in a high-quality manner if we didn't ensure their referral to social services. Provision of adequate social care and support shall become the key task of the governmental and the non-governmental institutions, because without quality social support, without addressing social needs and problems, we might be facing relapse and inefficacy of treatment. Which is why I personally believe that today's national forum has to become a professional platform of experience exchange, because on one hand, we see plenty of experts who are working with the topic for many years with HIV, viral hepatitis, substance use disorders, and I believe this shall become a platform that would develop efficient solutions. In what way integration shall be taking place in the future under the conditions Ukraine finds itself in? Using this opportunity, I would like to separately express my gratitude to the government of the United States of America for the systemic support they are providing to Ukraine. And this is not just the issues of humanitarian assistance, but also military aid. It's crucial and critical for us under the conditions of the full-scale invasion. And we extremely gratitude to government of the U.S. for their long-standing systemic support to Ukraine. And I would like to express my gratitude to the armed forces of Ukraine, thanks to whom we can conduct events like this, have free discussions, and feel ourselves safe. While, well, sometimes staying in the shelter, sometimes at home, but for sure feeling the protection. And I would like to express my gratitude to all the healthcare workers for keeping the medical front line, including at the frontline territories, that they continue doing everything possible to preserve health of Ukrainians and for health of each and every Ukrainian to be really robust, and for there to be no complications, so to say, because of the lack of desire to get certain type of care. I'm grateful to the organizers, and I'm sure that in the course of today's forum we will work out and develop good and useful solutions on the side of the Ministry of Health. I would like to assure you that, as always, we are ready to get proposals from the professional community, take them into account in our policies. And for us, this is equally important, because we have to understand what are the weak spots of the system, what are the weak elements within certain pathways, and what managerial decisions can actually improve the situation as of today, those that can have maximum effect to control the epidemics of HIV, TB, and viral hepatitis. Thank you so much, and I wish everyone a fruitful day. Thank you, Mr. Ihor. Thank you so much, and this is great that we can actually join with our applause the words of gratitude to the armed forces of Ukraine and to everyone enumerated by Mr. Ihor, those who are defending us and are defending the value of our life. You are working on the quality of. And I would like to invite Volodymyr Kurpita, Director General of the Center for Public Health of the Ministry of Health of Ukraine. You're welcome. Good morning, dear colleagues. After this night, it's difficult to speak, especially for those who stayed in Kyiv. But life goes on, and I believe that's the key difference, the key lesson we've learned within this 5 years of full-scale invasion and 12 years of the war in general, that even in the most complicated conditions, we need to think about the future. And this differentiates us from our aggressor neighbor who are still fixed on the past. I'm going to have a separate presentation where I'm going to tell you about the plans, and I would like us to get concentrated namely on the future and for us to think what we are going to do in times of war and after the war for Ukrainians to live their decent life, for us to be a healthy nation, and for our nation to have that very future we all dream about. Glory to Ukraine. Glory to heroes. You had a very short speech, Mr. Volodymyr. It was even late. I wanted to drink some water, and voila, you've ended. Please support me and support Mr. Volodymyr Kurpita with a round of applause. Thank you so much. And now I would like to invite Ms. Pamela Foster, Health Programs Manager at the U.S. Embassy in Ukraine Office Assistance Coordination, to deliver her welcoming remarks.
Good morning, everyone. It's always such a pleasure to be among such distinguished friends and colleagues, and I can't think of a better way to start today than with all of you. Once upon a time, we learned the lesson of public health, which is that good health is not merely the absence of disease, and I think the conference over the next 2 days gives us a chance to remind ourselves of that. We look at the person as a holistic patient, not as just a disease to be treated. I think that the importance on patient-centered care, the importance of mental health support, and the importance of looking at the health system as a whole will again be a feature of not only Ukraine's service delivery today, but service delivery going forward. It's a distinct privilege and pleasure for the United States to partner with the government of Ukraine and a number of agencies and bodies. We work with the Ministry of Health, the Center for Public Health, the National Health Services, the Department of Veterans Affairs, and the needs are immense, and Ukraine's ability to respond to those needs is even more immense. I look forward to the discussions today and to working with all of you. Thank you so much.
Thank you. Thank you so much for joining us.
And now I'd like to invite Kunta Dravnice, Director of the Supporting TB Control Efforts in Ukraine project, funded by the U.S. government and implemented by PAS in Ukraine. Ms. Kunta. Good morning, colleagues, partners, friends. I'm very happy to greet you today. And we often speak about integrated care, about system, but we need to start with a person. And this is not a case, this is not a diagnosis, and this is not a line in a medical record. Every person has got their own story, their own pain, and sometimes several medical and non-medical challenges simultaneously. And a person shall not be trying to combine all the elements of the system on their own path. For many years, years has been supporting the efforts of Ukraine in strengthening the healthcare system. Together with partners, we are supporting the provision of services which is person-centered, decentralization of services, and bringing care closer to people. And I'm sincerely grateful to the government of the United States for long-standing support, for trust to past, and for what we do in Ukraine. I'm very grateful for the support of this forum. For us, this trust is a huge value, but also a huge responsibility. Preparation of the forum required plenty of decisions, a lot of work within the short period of time, and I'm grateful to all the past team, everyone who worked on the contents, financial issues, and logistics. And separate thank you goes to Natalia Zaika, my colleagues, Oleksiy Kosivchenko, Irina Yanicka, and Elena Pavlenko. I believe we are becoming better and better in organizing events, but the final assessment is going to be provided by you tomorrow. I really would like this 2 days to be a friendly, open space where we can speak friendly, openly, and together look for practical solutions. And the key thing would be that this forum is not just a good conversation, but a next step towards really integrated care with appropriate continuation, close cooperation, and visible progress. Thank you so much and welcome. Thank you, Ms. Gunta. Thank you for this inspiring and motivating words. 1 second before I say, dear friends, the National Forum Integrated Care Strengthening Ukraine's Response to TB, HIV, Viral Hepatitis, and Substance Use Disorders is officially launched. A round of applause. And now we are going to proceed to the presentations proper to the panel discussions. But before this, I would like to test out what the QR code means. Let us do this just now. If you have a badge, scan your badge or scan it from the one from the stage. I have a little survey for us to actually have a look in real time. What is our understanding of the human-centered approach? By the way, our forum is available online, and whoever is watching us online, that's much more people than we have offline. You participate as well, please. So, I strongly hope you all scanned the QR code now, and I would like to ask you to proceed to question 1. Complete the sentence. Integrated care is first and foremost. Choose the option from the list below that you think best completes this sentence. You have, 1 minute for that. 60 seconds to answer. I believe that you, in your heads, have got your own notion or definition what integrated care stands for. Well, at least we are going to deal with this topic today, but it's interesting to know your opinion. Integrated care is first and foremost. What is that? Choose the option that suits you most. You can see the options available. My 60 seconds are clicking in my head, and I strongly hope they are still there. They are not over. We're going to be mindful of the time today. But we don't have timers. We will be based on our gut feeling, the biological clocks inside ourselves. But, you really have those inside of you because you're people who work in healthcare. Okay, we can proceed to question 2. And to what extent is medical care for TB, HIV, viral hepatitis, and substance use disorders integrated at your facility in your area region today? Rate on a scale from 1 to 10, where 1 services are arranged primarily separately with weak coordination between facilities. 10 There is a coordinated care pathway, shared responsibility and collaboration among service providers. So, let's rate it from 1 to 10, and you understand the scale. Well, I believe you have 45, 60 seconds in order to provide your personal response, answer to this question, and then we will have a look at the results.
So let me repeat the question. To which extent the medical care in Ukraine in tuberculosis, viral hepatitis, and dependencies or substance addiction, your health facility in your region of Ukraine is integrated to an extent? So 1, which is the most minimal part, and then 10, which is when everything is great, and then if it's not perfect, then I don't know if something is perfect in this perfect world, but at least close to perfection, to what you think is important for today's situation in terms of services provision. Our time is up for both questions, and I'll ask for results to be presented on the screen. Okay, so the first thing of the first question in integrated care, as I see that we have the biggest number of votes went for multidisciplinarity and human-centered approach. Honestly, this is something about Ukraine, so I guess multidisciplinarity and human-oriented or person-oriented approach, this is for everywhere in our life. We're so happy to count for ourselves, for our own devices, and ourselves helping, and then we are seeing how systematic it is, partnerships. So I would like for those results to consider the points of anchoring in future discussions, and so we can went to the results of the second questions. Let me see. We have the following. 1 is the worst, which is 3%, which I think it's making us happier. And then first of all, you see the green bars, even though they're like, you can argue because on 7 and 8, or 6, 7, right? And here is 6, 7. And those indicators, I think for us, it's like a anchor, because you know that things will be, the medium assessment is 7. So I still don't understand the thing in that, but I think that this is not a bad indicator. I'm not sure on the topic, but I feel like it's a good thing. It's much worse than it's red. So we have things to talk about. So we are moving to the working part of the forum. This is an error coming, and I'll be, if you would allow me, I'll be announcing the speaker, and then with our approval from the organizers, will be informed to which extent are we in the red or are we still in the green. So the first presentation will help us to discuss the key issues. What specifically do we understand under the integrated care? So where does the system move to, and what kind of changes have been planned, and what kind of solutions are needed for the integration to work not just in the documents but in the real pathway for humans? This is why we did the assessment before. I can welcome our speaker to the floor, and I'm making it with the greatest pleasure. And yet again, I'll ask for Volodymyr Korpita to get back to the stage. Director General, Public Health Center, Ministry of Health of Ukraine. You probably understood why I was speaking this shortly, because I'm going to be taking long, and you might have water and then also rest a bit. So when I'm among the people who know so much about health, then I can drink something else, whatever you say. And then if you would allow me, Volodymyr, I would just like to make one announcement. Whoever needs headphones for interpretation, this is the moment when you need to take them and to select the language of your choosing. Therefore, please proceed. Good morning again. Good morning. When we are saying about the integrated care, there's always a risk to say that there are structures, packages, orders, and in 5 minutes, everybody in the room understands that this topic is very important, but really is not clear at all. And it's not clear to whom and for whom are we trying to implement this. So I think that it's worth starting from a very simple idea. A person doesn't come to a healthcare system as the HIV or TB treatment program. They're coming with their own lives, and in that life, there might be a few issues coming in so far. On top of that, there's war, anxiety disorder, loss of residence, displacement because of war, and then the person doesn't have a separate 4 lives for 4 programs that we are mentioning here today. Therefore, we will try to say a few things, not how to merge the system together, but how to make a system unified for the person. And because of that, the topic of my talk, I've changed it a bit, and I put into the name that we are saying about one system, aligned services, coordinated services, and joint responsibility or shared responsibility. But let's start with the context. In the past few years, we're seeing significant changes in HIV epidemic. You can see the decrease of registered cases and the prevalence as well, especially on the incidence. You can see this from the 2022. But it's not worth arguing about each number on this slide because numbers are needed for other purposes as well. They're showing that we can't work with the logic of the same model of services for the whole country because the map continues to demonstrate a big regional discrepancies. The epidemic is different. The risks are different. Conditions for health services access is different. Therefore, the next stage of HIV combating is not about more services. It's about how to merge services and to tune or adjust the system so that it can actually answer to the needs of the patients. And in the same similar picture we are seeing on TB, in the first half of 2026, we have over 7,000 people with TB. This is much less than pre-full-scale invasion time, but the mean indicators on the war, they're showing vastly regional differences because we can detect a case, we can have a modern lab diagnostics, effective treatment, but the result is whether the person started the treatment on time, have they continued the treatment when they moved to a different region, have they received support, or haven't they been lost to monitoring between the primary care and other services. So the clinical result is not within one room, but it's in between the doctor's offices. This is also how the system is set up. Regarding the viral hepatitis, in 2025, we've detected over 1,500 Hep B cases and over 7,000 cases of Hep C. This is small numbers because the indicators, the assumption of the indicators that are showing us a much higher burden that we have to expect and the prevalence to be much higher, those infections. But I would really like to stress here that there's just one important option for Hep C. We are having a situation when the health system is much faster than the organization of the system itself, if that makes sense, because at this time, they present effective treatment that can cure most of the people. And this is a great leap of progress for all of us. But the question is not really if there's an effective treatment available, but the question is, are we finding a person that has to be tested, or whether we have to confirm a diagnosis or prescribe a treatment? But the modern healthcare has given us a great instrument for elimination of Hep C, and our responsibility is to build a system that is able to use the instrument. Another good showcase, which is the opioid substitution therapy, and we see what is happening is an increase in number of patients from 33,000 cases in 2025 or patients to almost 39,000 in August of this year. And I would really like to point your attention to the numbers on the bottom of the slide, which is the great achievement in and itself, because over 90% of patients are receiving for self-intake, self-guided intake. And so to which stage this is important, the role of the patients in following the treatment plans and everything else. And therefore, almost all of the patients that require ART treatment, they're receiving them as well, most of them in municipal health facility. And this is a great and a bright example of the specific kind of integration, because we are not telling a person, let's solve your dependency or addiction problem, then let's deal with HIV or TB. No, we're learning to work with the person with whatever they came up with, or not the one that the system would have wanted to see the person. And this is bringing us to the main question of today, which is, I would like to start from a, quote-unquote story that most of you probably know, which is the complex pathway of different situation. Let's imagine a Ukrainian, let's call him Andrew, and then he's slightly over 40. He came from Pokrovsk to Lviv, so from east to the west of Ukraine. He has an experience of using opioids before, but because of the outreach program, he got into the OST program, where he got HIV detected, and then due to testing Hep C. And then he starts coughing, and then what happens later on? OST in one place, HIV services in different place, confirmation for viral hepatitis in a different place, and then for testing for TB, there is a separate patient pathway. And so here you just need to talk about the psychologist, psychiatrist, social care, and each one of those experts can be really good at what they're doing. But there's a paradox when everybody's doing good, right? But then the person's not getting the results they receive. And we like to draw patient pathways, right, on the wonderful flow charts during meetings, and then the issue is only in that the patient is not really going around the city with the PowerPoint presentation and don't know where this arrow on the flow chart is leading us. So we are turning the patient into the courier between different parts of the system. And here the main challenge for all of us is, since historically speaking, vertical programs has given us a very good intake and push and have been a great advantage in the beginning of the combating of the outbreak. And so they created expertise, labs, strong professional teams, and our main objective is not to destroy what's there. Our objective is to build bridges between those vertical systems so that this Andrew would find his place on those bridges and everywhere else. And it's very much important to agree, what are we calling an integration and what are we not calling as an integrator, where there is this myth and when there is this reality. The integration of the services, this is not just an administrative merging of all of the systems together into one, and not establishment of a human institution. And it's not the removing the personal expertise or anything. And this is not the phrase, so let's put everything to a family doctor and the problem will be solved. If we will push this function to the primary care without the competencies, without the time to prepare, without the funding, this is just putting the same issue on a different set of shoulders. And then specialization, I feel like it's very important to preserve that the specialization is supposed to be responding to the complexities, and then for the connection with especially integrated care, this is the information this is needed where the patient reached out to, approved upon clinical decision in the system, where the person doesn't need to start telling his story from the ground up. Integration, this is not something that we've created as a country. This is the general pathway for the health system transformation. In the framework of what WHO does and the integrated human-centered services, they are proposing a systematic change from the system of organized around diseases to a system oriented around the needs of the human being. Human being has to receive care needed at the needed time in a more accessible place to that person. In different parts of the system, they have to work. And then the integration is a group upon data, funding, and everything else, and other things. And we are seeing the same logic in the global strategy of WHO and HIV. And then viral hepatitis in 2030, and then the strategy itself of the health system, and then those targets, the universal access, intersectoral coordination, development of the potential of the system, they are creating the national framework for that. We need to move from the integration of separate programs to the integrated health systems. And then what else can be changed for what kind of barriers are obstructing them to receive the unobstructed care, and then what else do we have to change so that those barriers would be as least as possible, and what else is important, that we are not starting from nothing, we are not starting from ground up. The last year the international assessment has been done on the international programs, and it decides upon a few strengths of Ukraine, and then we have the bylaws that are allowing us to look at HIV, TB, and viral hepatitis and OST, not as an isolated list of stories, but as the unified system. What Igor had mentioned, we preserve the key services, deployed mobile units, and then one facility is in one context, and then the safety context in a completely different one. And this third thing, which is very important, that it's the public sector's work. So for many public organization, and then they're the first doors of the system, and our discussion have those strong elements in which the international partners, they're saying they're supposed to be developed, reinforced, and deepen. The 4 levels where this has to happen. The first level, which is the patient pathway, I think that we can speak about, and then the provision with medication and preservation of the logistics and everything else. Because of there's no test, and then if you're not integrating the system, then they're not going to give the results. On the integration of services and data, we'll be speaking tomorrow, and then we're still moving in this area of work. And the number 4, which is the most important managerial decision, because the integration is not finishing near the doors of the even if clinical pathway that we were speaking before, which is integrated, but together with that, it's fragmented, and then nobody's seeing the full results. The systems continues to be fragmented, and then the integration has to be through all the infrastructure of the health system altogether. And in my opinion, for Ukrainian context, it's worth to differentiate like 2 different things. Integrated care that describes how the system is built. So how does the services providers are aligned, different levels of kinds of care, and maybe there are different information system, but from another side, the continuity of care that describes the results for the person themselves. And then it's so important to understand if they have a transition from the prevention to screening, from screening to treatment, and whether the person was lost or the practical integration part, which is the number of services that are being provided in one room, but also the ability of the system to provide for a patient pathway. And then the services can be easy to use, but they're not like having the integration. And then e-prescription is not good if the person did not receive the medical care, and then the result is getting back to whoever's doing that. And then for viral hepatitis and substance abuse, the referral was the feedback or closed loop referral. When the system is not just giving the person to another one, but finishing up that approach and the future decision. And there's operation decision, there's no incorrect errors. Any relevant entry point, if this is primary care physiopulmonological care, and then HIV services or NGO, they have to have the minimum of the competencies for the detection of the related problems and basic screening conduct, and then provision of the primary services was then guaranteed transfer person to next stage of care. And then the integration of the universal doctor, and then they have to make the universal ability of the system to not to miss the need of the person. And then we need to stop thinking as if there's just one correct point and one correct health facility, because every service provider and the need of the person, and then provide for additional steps. The last role of a primary care does not mean that the family doctor has to be pediatrician and then psychiatrist or dependency specialist, but they need to have a capacity as any other specialist to see the risk and then to make it so that you can fulfill something on your level. And then one of the main things is that to pass the person along, so what they have to do on the next stages. But then the most important part, if not to lose the person between all the stages. Why does the integration is needed for today? Because of course we're seeing that there is an epidemiological or other kinds of needs. And it's not a secret for anybody that HIV, or people with HIV, has a higher need in the terminal detection and treatment of TB or viral hepatitis is because of their status. People who are using injectable drugs, they need an access for an evidence-based proven treatment and prevention of overdosing, mental health services, and other kinds of things. And so overall, WHO says that opioid substitution therapies is one of the most important continuous part of the national system for health. And in such conditions and preconditions, separate planning of the programs without a line pathway creates an overlapping in the same point of cares and gaps in other points. Another reason, which is the change in the model of health services provision. So Ukraine slowly is moving from the overtop in concentration and mono specialized health facility to wider use of military care, outpatient care, multi-profiled and capable network, capable health facility network. For TB, this is already in bylaws. The list of services, how services are provided in outpatient settings in the primary care facilities is decides upon this mechanism. The same story for decentralization and differentiation has to be used and is used for HIV, and hopefully will be used in viral hepatitis and between the specialized and primary care. The third reason is the war, because the strategy for health system development that I've dedicated to, it just intakes the full-scale invasion has led to the destruction of the infrastructure, migration of the population, and then disruption of the possibility to follow patient pathways where it was disrupted. And for prolonged states that or chronic things like HIV or TB or viral hepatitis, where the treatment can last for months and years or lifelong, the dependence on the system from the health facility becomes an additional added risk. Continuity of care has to be provided with independently on the moving a person between the regions, and then the experience like that we already have. And then between the civilian and military sectors, and then being on the near the front line or deoccupied territories. The fourth reason, which is the financial institutional capacity, and then because vertical programs have developed with the support of international partners, and then created a separate procurement and then data and other things, which allow us to achieve progress. But the system has to build a critically important in the national finance and everything else. So the sustainability means that the needed service has to have a continuous source of funding. Define, procure, and the services provided doesn't exist until they're supported by a project and by the system. And then the fifth thing that was mentioned already, which is the European integration. in our opinion, and then it doesn't see foreseeing the operational models of the separate countries here, and then just foresees the getting closer to the principles of universal coverage and the evidence-based and protection rights, and then the rules, rights and the patient, and working with the vulnerable groups of population. In terms of narco policy, the new strategy to 2030, and Euro integration, and then the framework also that it's built, that the harm reduction, and then they have to be as connected components. And then not as the fundamental thing, or as a foundation, as the whole building. So a family doctor can coordinate pathways, and they can do like basic screenings, and then or manage a stable and reliant patient. But the specialized care is critically important, that I mentioned before. So this is very important. We would like to highlight the need for an increase of the public health system and the Center for Disease Control and Prevention. And then that has to fulfill the key function of the public health centers. And then we are working at the for the algorithm, and then an updated order on the epi-surveillance on TB. Right now they're in approval from the Ministry of Health, and then in September we will initiate the national consultation on the new order or procedure of the epi-surveillance on HIV that are now initiated by the Public Health Center. There are significant changes in approaches to detection, diagnostics, and registration of cases that have to aid the integration process. And of course that we have to understand the role of the NGOs and other organizations that have something that the government or the states cannot create, and then the trust of the, and then that is recognized by international community, and then the integration. Every square, then they know how to work. And then regarding data, the digitalization with the names of the system, and then what has to happen with the person. If the doctor sees the need and creates a referral, then the person has to receive a support and where to go to, and the freedom of navigation, so to say, and understanding when they need to go to the next stage of care, and then to check if they actually did this or not. And then the next services provider has to deal with the result, and the initial coordinator through the feedback system or feedback loop system, they need to know that what was planned for the patient has already been fulfilled on it. This is this closed loop. And those IT solutions, they're not a self-fulfilling objective. It's just like to say that it just leads to the way that the system doesn't forget about the patient. If we create 5 wonderful IT systems that doesn't speak to each other, this is going to be a modern way of system that we just have right now. But apart from the person with the paper-based forms between the rooms, we're just going to have the e-prescriptions, and then that are not going to go anywhere, really. And another thing that we need to decide upon ourselves, that the clinical results and the clinical outcomes doesn't really depend upon which kind of medication has been prescribed by the doctor, but since the person can have the best possible regimen for treatment, but not have the funds to get to the health facility, or not going to have the documents or ID or anything else, or be afraid of the drafting or mobilization, or just to live near the front line of the war. And here is the NGO functioning, the peer-to-peer consultation, social workers going in. It stops being a separate or additional option. It becomes a part of the results of the treatment. It becomes part of the outcomes, desired outcomes. And that's not just the role of the public sector and the NGO or essential NGO sector, but how to institutionalize what they do. And for that, you need to specifically decide upon the function, have the mechanism tools for referral and referral between the state system and the NGO system, and have the stable sources of funding for the NGO sectors and then the public sector as well. In parallel, we have another level of information, which is the public health epi-surveillance. And here, it's important not to mismatch those systems, because the needed information for the specific person is one thing, and for the public health system needs an information what is happening with the population and populace altogether, because the incidence is growing. For example, what are the types of outbreak? Where are we losing people in the cascade of care, and we'll get to the numbers to care, and where do we need to change things? And therefore, an e-health system and medical information system, so and other system, and social significant diseases medical information system, but they have to work in the agreed upon IT space. So together with the National Health Service, we can be working on the establishment of the data exchange API between the e-health system, medical information system, social significant diseases, NSM, and then therefore the objective is not just to collect the most data, but just to make it so in a way that the correct data in the correct moment of time would allow you to make a correct decision that we just want at that point of time.
And for sure, there shall be a roadmap. If to translate everything mentioned into this roadmap, it would include 6 stages, and I'm not going to reiterate what I've mentioned already because I partially touched upon those, but we believe that, namely, in this way, we need to change the logics of the management of the system. If we try bringing it all to the image of the system 2030, we would like to be speaking about 4 key transitions: from patient who are searching for the care themselves to the system that finds the patients and support them, from treatment of the consequences to prevention of risks, from fragmented services to the referrals, and from the reporting for the sake of reporting to the data that changes the managerial decisions. And the key thing would be that we have to understand whether the person feels where one institution ends and the other begins. If they have to know the structure of the Ministry of Public Health Care, the National Health Service, the PHC or Public Health Center, it means we didn't do our job properly, because this information is needed just for the managers, not for the patients, and we cannot require this from the patient. And to crown it all, I would like to come back to the example of Andriy, with whom I started this presentation. There's no HIV, hepatitis, or social component programs. There's just one question: whether the system helps them to continue leading a normal life, which is why our key task would be not to make these programs the same, but to coordinate them appropriately whenever they have to emerge in life of one person. So I strongly hope that in these 2 days of the forum, we will really start proceeding from the general agreement that integration is needed, because we all know it, to more complicated question: who, what, and how shall be changed for this to become a daily routine. And to finalize it all again, to improve the continuum of care, we need to proceed from the totality of separate initiatives to the standard integrated system we were discussing. Common responsibility, well-coordinated data, because integrated care is not about how well our structures are combined on the scheme. It's about whether it's easy for a person to go through the system and not get lost. Thank you. Mr. Volodymyr, thank you so much. You really provided very great presentation. There are no questions from the audience, but I would like to remind you that using this QR code, you can actually be asking certain questions of the speaker. And if there's time, it's important to highlight, we are going to ask these questions after the presentations. So now, actually, we are going to listen to a range of presentations, because this very block of our agenda is dedicated to coordinating efforts and organizing integrated care, the systemic challenges and existing barriers. This is quite an interesting session for experts of the PHC or Public Health Center. We'll consider a continuum of care from the viewpoint of TB, HIV, viral hepatitis, substance use disorders, and mental health. So, this segment of our program is going to be comprised of 2 parts: 4 individual presentations, followed by a joint discussion. together with all the speakers, actually. So, at first I will invite our speakers to present one by one, and after all the presentations are complete, we will gather on the stage for a joint discussion, and maybe you'll get an opportunity to ask questions. Now I would like to give the floor to Ms. Yana Terleyeva, head of the Tuberculosis Control and Prevention Department at the Public Health Center, or PHC, of MOH, to discuss the topic systemic challenges in combating TB, signs of challenges, epidemiological data, and monitoring data. The floor is yours. If you've got the headphones, please use the language of your preference. Greetings, everyone, at this national forum. This is a great opportunity for a frank conversation to discuss where the system operates well or where it requires introduction of certain changes. If we speak about integrated care, in case of TB, we understand that we have strategies, visions, up-to-date standards and algorithms. In practice, we sometimes see that this system might not work properly, and our task would be to understand what is the challenge in practice and what are the growth points. I would like to start with the most important and the most complicated pathway of a patient, of a client who is actually healthy. Pathway of a client on TB prevention. And actually speaking, what we shall start with here, unfortunately, the stereotypes we have in society today pertains to prevention being something unimportant or secondary, and the stereotypes are there, not in general in the society, but even among the healthcare providers. And we need a conditionally healthy person to be getting preventive treatment from TB at the level of WHO in order to change this attitude. Actually, WHO has got these more complicated terms when we don't speak just to prevention of TB, but identification and preventative treatment of tuberculosis infection. And if we have a thorough look, the first entry point would be namely identifying what people require checkups for tuberculosis infection. This would be the first entry point in this very pathway, and we have to recognize that regardless of the fact that we have up-to-date standards, algorithms, there's access to diagnostic tests to identify TB infection, but according to the data of the previous year, this would be PHC data, just 1 out of 10 persons who required TB checkup was actually examined. Actually speaking, this is something we need to do at the primary healthcare level. This year we've improved the situation. 60% of the patients have already undergone this diagnostics at the primary care level, but this is not the result we are striving to achieve. We need to achieve 100% because the price is too high. Unfortunately, today we say that TB is curable, the condition, and there are all the opportunities to protect a person from development of TB. At the very same time, we still see the tragic stories when people are getting complicated organ transplantations or are requiring dialysis and nevertheless are dying because of TB. We have to change this, and, well, in order to regain trust of the society to prevention, to healthcare workers, to these methods, and we are grateful to donors who support us today, and we in general have really innovative methods and new quantiferon tests and other rapid tests, but the situation requires further solutions. The next thing where we already have achieved successes, majority of clients with whom the TB was already confirmed are actually getting treatment, and moreover, they didn't just get treatment but successfully finalized it. More than 90 people, 90 of those among this category finalized their preventive treatment. This was possible thanks to the fact that today we have short-term preventative treatment schemes, and our countries actually taking a leading position because 86 people are using this short-term schemes. We need to continue working with the citizens of Ukraine, those who are in the risk group, continue cooperating with family physicians to boost their awareness, and for sure conduct awareness-raising campaigns to improve prophylaxis and change the paradigm in general within the TB countering system, for us to be actually abandoning the programs oriented at control and treatment, and to be approaching the programs that will be aiming at prevention of development of TB. The next thing would be a pathway for a person with possible TB, and with possible TB, not the suspected TB. A person can be suspected of crime by an investigator. This is not the term we're using nowadays. So a person who is not getting a TB treatment might be the source of infection for those around them. So we need to start with the fact that within the recent year, the country had a breakthrough when all the conditions were created for timely TB diagnostics, and we have a powerful network of up-to-date molecular and genetic systems that are available in every community. As of today, we have great equipment, computer tomographs, and we have new point of care that are going to be available thanks to donors in our country. But also let us have a look. Why a pathway of a person since the moment they feel the symptoms of TB till the confirmation of diagnosis consists of 46 days. It's a month and a half with possible diagnosis, and the person is traveling from institution to institution without the confirmed diagnosis. At first, we need to mention that, it's not enough to have a CT if there's a line of people waiting to get CT. It's not enough to have molecular genetic tests that can set the TB diagnosis just within few hours, when the logistics of biological samples is disturbed, when people have to wait for weeks for their biological sample to be sent to the nearest laboratory. So our task would be, on one hand, to talk about the symptoms of TB, raise the awareness of the population, and make it so that the up-to-date diagnostic opportunities are there for the patients. And let us proceed to the next final pathway. That's a pathway of a person who contracted TB. And we need to start with the fact that in Ukraine we had a colossal breakthrough. We can treat TB using up-to-date standards that are available in our country, and unfortunately there's limited access to those in some European countries. Well, actually, the treatment would be the treatment of TB would be just 4 days for a system when the 9 months. Previously, it was taking years. We've changed paradigm. People with TB are no longer treated for months in TB inpatient clinics, but 80% of people start the outpatient treatment. This is part of human-oriented support, I should tell you. But at the very same time, let us have a look where we have gaps in the system. Well, the gap is that just 1/3 of the patients who are treated in an outpatient mode are getting this treatment from the family physician. This might be related to the fact that family physician might not understand what to do with patients like this, and they are not always eager to treat patients like this. We are trying to overcome this barrier, and Mr. Volodymyr was mentioning that starting from the 1st of September, all the medical and sanitary care institutions shall comply with the conditions, shall support TB patients who shall be treated by family physician, because we see that if the system doesn't work properly, regardless of access to great technologies, every 9th person can be lost in the healthcare system, and they are not finalizing their treatment. So we have to understand that actually the key goal of ours would be to change the philosophy We shall not be treating this patient as non-adherent, problematic, but we need to understand what barriers this specific person is facing and what we have to do for this person to overcome these barriers. And namely for this, we have to reformat, reorient, and strengthen the tools we have in our country. That's the medical and psychosocial support programs. Ensure that people have access to those. And regardless of all the barriers faced by patients, be it loss of home, fear to lose job, long traveling time to institutions, we still need to make sure that the patient will actually have a successful journey to overcoming TB. So we have a unique opportunity today. Actually speaking, within this 6 days, we can diagnose TB and a person starts getting anti-TB medicine. You know, a few years ago, this time frame was 35 days, now 6. Can we move further? Can we believe this is a success or just an interim point because we have a goal to decrease this time frame to 3 days? And proceeding further to the topic of today's forum, integrated services for people with TB, I would like to mention that a person with TB rarely is a person with just TB. And it was already mentioned today. Usually this would be a person with comorbidities like diabetes mellitus, HIV. This person might be an IDP or internally displaced person. And we cannot be looking at one program from the viewpoint of a one diagnosis, one approach. No, we need to understand that there must be additional opportunities, and these services shall be oriented at the needs of every specific person. We can actually look at it through the prism of gender aspects. When we understand that majority of people who contract TB, 75% are namely men, 25% are women. If we speak about men, the barriers and the complications men are facing would be how not to lose an income for the family if I contracted TB, how to perform my military functions if I have family and I need to treat TB, and for a woman who is going to take care of my children if I need to get TB care in the inpatient setting. How do I ensure that my home is safe if I need to be treated from TB? But regardless of all this gender diversities, there's something which brings every patient together. More than half of the people with TB do not have income. They are not employed. Every second referral of actually tell us that these people come to get assistance and help and some compensations if they have some financial hardships. So, other barriers we have to work with today in the conditions of war. 60% of people feel psychological aspects, anxiety, stigma. So we need to speak about comprehensive approach here. And, in terms of integration, we need to mention that we don't speak enough of stigma. Stigma is one of the key barriers that are standing on the way of countering TB. That's the aspect that brings together all those social therapeutic areas we speak about. Every third person continues facing stigma, though in the country we support the European values system. Our task would be to proceed from stereotypes related to TB to support programs. We need to reach a hand out to those people who are facing the TB challenges. When we speak about TB countering program, we can group up the three main pillars, three fundamental barriers actually related to individual factors, systemic factors, as well as thirdly, societal factors. Our task would be to coordinate it all at every level, the individual, the systemic, the medical, the social component. We need to identify the role of local self-governments, of civil society organizations, and we need to have a comprehensive understanding and comprehensive solutions to these barriers people are facing when treating TB. And to finalize, I'd like to mention that in fact, robustness and efficiency of healthcare system is assessed by the weakest link in the pathway of a patient. So our task would be to get focused for all the services to be patient-oriented, regardless of the fact where they are getting assistance, what obstacles they face, and we have to be speaking about ensuring access, and even under the conditions of war, access to healthcare shall be there, with due account of the new models that are available in our country as of today, mobile laboratories, telemedicine. We shall offer coordinated assistance where a person would not be lost within the different elements of the healthcare system, and they know where to resort to and where they are going to find help. The solutions we take, they shall be taken on the basis of those data which are there. But data shall be full-fledged, high quality, and they shall be integrated, and we need to use them, including use the potential which is out there for the data, for the monitoring, and we need to use the evidence-based data. So, and for sure, continuum of care, because continuum of care is the vital part of a pathway at any level. Since the moment they have not yet contracted TB, if they contracted it, then not till the moment of curing TB, but up to the moment when the person can full-fledgedly come back to their life and can be integrated back into the society. It's not the person who shall be looking for the pathway in the system, but the system shall approach this person. Thank you for your attention. Thank you, Ms. Jana, so much for your presentation. We are not saying bye for an extensive period of time because all the speakers of this session are going to come back to the stage after individual presentations are finalized, and we proceed to the next speaker, Ms. Larissa Hetman, head of the Department of HIV Management and Prevention at the PHC of the MOH of Ukraine. We'll discuss important aspects of combating HIV. Greetings, dear colleagues. Please show my presentation. Well, it's there. Today we are going to speak, well, today and tomorrow, we're going to speak about the issues pertaining to pathway of a patient, but we clearly understand that pathway of a patient would be a tool that helps in providing high-quality services. And for more than 10 years, Ukraine, as the whole world, is assessing the cascade of services. We were calling 90-90-90 till recently. Now we have 95-95-95 up to 2030, meaning those who are covered with the services, who are covered with care, and the efficacy of the treatment. If to speak about the cascade, we have, as of the 1st of January 2026, 89% out of those who are in care are covered with ART, meaning they are covered with treatment. Out of them, 97% have got efficacy of treatment. Unfortunately, because we don't have data from temporarily occupied territories and because of impossibility to get demographic data from there, we cannot full-fledgedly speak about assessment data, and we cannot properly assess the whole cascade of services, to speak about assessing the results of combating HIV in compliance with UNAIDS approaches. But if we speak about access to treatment, if we speak about ensuring efficacy of such treatment, then within the recent 3 years, we see the best outcomes. Well, for sure, we can discuss the fact that within the recent periods, we are decreasing the identification of new cases. We see less people covered with care. But the data are self-explanatory, the ones you see here. You know, behind this data, there are always people. And if we speak about the results of 2025, among the newly identified cases, on average, really more than 60% would be men. The average age would be 40. This would be residents of urban areas. This would be STDIs, and usually these are the citizens of Ukraine. I reiterate, unfortunately, for several years in a row, we are registering new cases of HIV. 60% and more are already in the later stages, in the advanced stages, meaning patients have got several comorbidities that are not interrelated to HIV, TB, viral hepatitis, STDIs, issues pertaining to substance use disorders, opportunistic infections, meaning as of today, treatment and provision of services to a person living with TB would be provision of services to people with comorbidities. And we completely understand here that namely this clinical and organizational interdependence requires integration of the services. And let us continue with the imaginary patient Andriy. He's okay. He was prescribed ART. The treatment is efficacious. The viral load is undetectable. Andriy had been screened for TB and got the negative result. He's getting prevention. There's depression screening. He does not require any interventions in this regard. The blood glucose, the arterial blood pressure, the lipid profile is within norm. The hepatitis C treatment was conducted, and again, the condition is within the normal. I enumerate it all, and I'm sure you clearly understand why I'm doing so. There's symptoms, there's conditions, and this is not the full list we need to work with, including social, psychological problems. Because we have to pay attention to these aspects as well. So, Andriy is okay now because these measures, these interventions were directed not at separate therapeutic areas, but at comprehensiveness of the services provision and integration of the services. Today we already spoke about the structures of the integration. I would like to emphasize your attention on certain important aspects, and they pertain to early identification, screenings, and this is really relevant if we speak from the viewpoint of HIV, TB, viral hepatitis, meaning we need to be targeted at early interventions, early identification. Patients living with HIV shall be timely diagnosed with TB. TB patients shall be timely diagnosed with HIV. Then co-management of treatment and prevention of all the therapeutic areas. Next, safe prescription of drugs of various classes. And for sure, we cannot do without monitoring, without adherence control, without develop adherence. And what's important, that's counseling, support, care. Not all the issues can be solved through medicines and within the healthcare system. For sure, we need assistance, and this doesn't take one day or 1 week or 1 year. This is about interaction of the public sector and non-governmental sector. I offer this continuum of care or services granted to our patients consider key things that pertain to achievements and challenges we see in the continuum of care. But before we dive into continuum of treatment, I would like to emphasize your attention on the issues of prevention and prophylaxis. We need to understand whether everyone who requires this assistance is covered with this assistance. So, identification, testing, it's available in every region of Ukraine, at healthcare institutions, the program of medical guarantees, plenty of packages are included there, not just in healthcare institutions. As of today, it would be granted at the level of outreach pathways, non-governmental organizations. A patient can, on their own, procure a test and be covered with the screening. At the very same time, we have great coverage with testing within the recent years, even more than before the full-scale invasion. But actually, you can see the results of 2025, 0.4%. So, with due account of the fact that more than 60% would be already the cases with low immunological status, we need to take into account that not each and everyone who could have been tested, who could have been identified, not by the clinical manifestations, but by belonging to the key populations or key groups, should have been identified earlier.
So I guess there's no reference point, but I just really like to tap on the enrollment under medical surveillance and monitoring. Those are great indicators. More than 90% that among the ones who are being detected, involved to medical surveillance, they are much better than we had a few years ago. So those disruptions and loss to follow-up has been much worse before. But we still understand that we have things to work on. This is both in terms of patient pathways, but also for everybody, it's going to be a separate thing. Somewhere, it's really the referral, and then sometimes timely information and other things, and then the beginning of treatment, that practically everybody who are included into the medical surveillance system, they started to the beginning of the treatment. And for us, this is important, which is this is timely onset of treatment in the first 7 days, so under 1 week. And then this is one of the best indicators for. And then there's the best in the health system, and then to the public society that boasts the motivation and consultation and prescription and other things. And then they're also represented and they have wonderful results as well. And it's important to have not just to prescribe the treatment, but also to hold the system in the medical surveillance system. And then if we, about the 3% that who's being lost, was they take into account the immigration processes, take into account logistics, and then take into account the full-scale invasion. And then also, by the latest results of 2025, this is the best results if we are to take into account the next 3 years. Monitoring of the treatment. And here, there's also things to work on. 90% of your... This is probably the best indicator that we have in the past period of time, but this is still not the 95 or 99%. The viral suppression for the ones who reached the system-wide, who's receiving treatment, and then who's ever been tested or treatment, they need to have an effective treatment. This is very important because right now, ART medication, they're looked at as not as the clinical point of view, but they're still lacking and then it's still working, and you need to remember about this as well. And the last thing that I think is the most important thing here in the continuum of services, which is quality of life. Quality of life, which is 0% of stigma, 0% of discrimination, and we can't really fight any issues, epidemic, disease, or anything that's of concern to us. And this is the decrease of mortality and new cases from HIV. And then the few other things that regarding the prevention, not to get under the continuum of medical services. This is a very important thing. On this slide, we have indicators, and then depending on the operational plan, they are very good in regarding the continued connection to the key target groups, and then regarding the mother to child, vertical transmission, post-contact prevention, and then prophylaxis, the higher indicators. And then we were planning to do this. But speaking about the plans for the future, they are still very much ambitious. And if you're speaking about post-contact prevention and other things, we are not in the vertical access to the person that's almost accessible in every health facility that are where you can reach out to. And also, if we are to say about the prevention and transmission of your mother-to-child transmission, and then the mother-to-child transmission with them, it's not just an infectious disease doctor and obstetrician, but neonatologist, pediatrician, and then NGO organization. This is the comprehensive service, and therefore you need to think of something wider. And then the country is dedicated to the triple elimination of HIV, viral hepatitis, and syphilis. Therefore, in the nearest future, this is also one of the things about the integration and the services, and for many times before, of services as well. And I would also like to touch upon the PrEP matters, and then as of today, and even the data that we are receiving, and then we would like to know even more and even better, 75% on the 2025. And as of today, throughout the world, PrEP and access to PrEP and understanding what the PrEP is, this is, I guess, one of the great achievements in prevention that we can speak of. And therefore, if medication is working, of post-contact prevention after the possible event of the contacting for PrEP, and then they are possibly working before the contact with PrEP, and therefore it has to be we need to make an additional testing. You have to make a run for it. And then in Ukraine, there's also access to a tableted form of PrEP, and then for prolonged injectable forms of PrEP. So we are on the stage of implementation of lenacapavir, where it's just one injection per 6 months that holds you for 6 months. And then therefore, it's worth mentioning here that in the matters of integration, referral, patient pathways, and PrEP as well, this is also our plans for the next period, so what awaits for us. And the key summary and the key reports. Ukraine supports the global strategy on receiving the targets 95 to 2030, and is having control on top of epidemic. At the same time, absence of assessment data or assumption data doesn't really allow you to assess the achievements that we had so far. But I'm really hopeful that with this ceasing of military actions and the full-scale invasion, we will have access to data, and this situation will be just like we had regarding in the cascade of services, just as we have before the 2022. In general, the results of 2025 are exhibiting to us that despite of all of the challenges that we are having as of today, the system for HIV combating is working effectively and showing great results and providing the services provision for the patients. At the same time, we do understand, and we have this understanding, that the losses and the continuum of care that are referring both to the prevention and testing and treatment, we do understand that those are ripping points, and we know where do we have to put our efforts to. And then the future reinforcement of our efforts for combating of HIV epidemic requires the future continuation of care and work regarding the integration of services, what kind of prevention, treatment, and testing, care, and support are being merged with other very much so needed medical, social, preventative services in one continuous, so there's a continuum of care. Therefore, thank you so much for your attention. Larissa, thank you so much to you. Thank you so much for being here and presenting. Let me repeat myself that we will see each other again on this stage, and so you've listened to the presentation of each of our speakers. Please formulate your questions, and then we will be continuing. Then the floor goes to Irina Skripka, an expert on management and combating viral hepatitis and opioid substance addiction. Irina will present to you the strategic area of work and efforts in our combating viral hepatitis, and will help you to understand better what is needed of additional attention for an improvement as well. Attention goes to Irina. Thank you so much. Colleagues, good morning, and thank you so much for your attention. I would just like to start off that Ukraine in 2019 has made as one of the milestones in combating viral hepatitis, and included the combating programs and viral hepatitis combating to the state strategy of socially significant diseases combating in that period of time. But are we achieving the goals that we've put ourselves, or the indicators that we need to reach in 2030? And I want to look at the cascade of services as one of the indicators of the patient pathways, the accessibility of services to them and for them in numbers and absolute numbers that we are having according to the statistical data that we received on an annual basis. And so we do understand here that the objectives are really high, but they are being reached in most of services that we are providing. For example, we are aiming to achieve on the screening objectives for viral hepatitis and also regarding the treatment as well. At the same time, what we are seeing is a significant gap on the confirmative diagnostics, and so we can speak about this a bit later on in the presentation. And so are we reaching the goals and objectives regarding viral hepatitis B? It's worth mentioning that viral hepatitis B, apart from viral hepatitis C, you can prevent it. Especially in Ukraine, there is a vaccine. It's accessible for children under 18 years of age. And there's also objectives and criteria in which way we were supposed to move forward, which is the objectives approved by the WHO. And as this time, we were supposed to be reached the indicator and 95% vaccination coverage by the first and the third vaccine for all the newborns cohort, and also catch-up vaccination. And unfortunately, we are not reaching those goals, and there are also gaps presented there. They're not allowing us really to present this services accessible to all the child. There are individual decisions of parents that are in play, and this insufficient awareness of the population about this accessibility, those services. But there's also this catch-up vaccination, and they're getting to the point to reach the indicator and 95% of the coverage, and right now it's at 90%. Regarding screenings, we are overachieving, and this is the general trend. There is a compliance regarding the testing for hepatitis B. At the same time, we have an assumptive numbers to how many people would have supposed to be detected with those screening, and those assumptions or that data, they're present as of 2019 and 2021. And so we are not really seeing what is the possible prevalence of viral hepatitis in the period of the beginning of the full-scale invasion, or those reinforcements of the military actions and attacks from Russian Federation. But it's this, at the same time, we do understand that we are insufficiently detecting, or this means that the integration is not sufficient, and we're not entering the key target groups that we were supposed to cover or give us the higher detection results. for viral hepatitis B. At the same time, you're also seeing gaps in confirmative diagnostics, meaning this is also a size of accessibility of diagnostics and quality of data, because we do understand here that the cascade of services is being fulfilled in terms of provision of treatment for those patients, and especially annually in the treatment program for viral hepatitis, around 1,000 of patient entries, so the novel patient or index patient that have not been detected before and they didn't have a confirmation for viral hepatitis diagnosis. And so we also understand that we are not reaching WHO goals because we don't have a sufficient number of patients that would be detected and therefore diagnosed. Diagnostics of viral hepatitis B is much more accessible because you don't have to receive the services on the molecular genetic testing. There are testing that are included in the program for project for package for medical guarantees, and the patient could have gotten them because of free of charge services provided by the government. And a special line of attention is dedicated to combating of viral hepatitis C. The objectives and targets on the combating programs, they're not just included into the operation and plan for the state strategy, but also is one of the priorities of quality of service within the Ministry of Health's mandate and also the government of Ukraine. Throughout the year, we were supposed to screen for 1,500,000 people, and access to treatment was supposed to be received by 50,000 patients. Are those services possible? Yes, because we have free of charge access to screening and treatment of viral hepatitis. The viral hepatitis combating program have not stopped in terms of funding for the state budget, even with the beginning of the full-scale invasion. Especially, we have free of charge services for patient on screening and also on treatment, which means that the patient can get the service on screening in 13 packages or program for medical guarantees. This is not just connected with integrated services with the socially significant diseases that was significantly mentioned before, which is the ability of integration to services on the screening with the packages of services or program for medical guarantees, in which there are target groups included that could have been infected by the viral hepatitis B or just general viral hepatitis. This is the patient on hemodialysis. Those are the patients that have like hematological conditions. Therefore, this can also be a non-patient, but a targeted groups of population. This can be people that are serving for or going for the military medical commission that were supposed to be screened for viral hepatitis, so that they can timely receive the confirmative diagnostics and access to treatment. Despite the fact that we have barriers with the confirmative diagnostics and with the monitoring of treatment and the assessment of the success in the viral hepatitis C, we are still trying to overcome this barrier by integrating the services of molecular genetic testing into the centralized system of Center for Disease Control and Prevention, or CDCPs. For that, I would like to express our gratitude for the donors that are supporting this program, especially providing with the confirmative diagnostics on the CDCP stations and the separate groups of population, target group of population or key groups of population among which the prevalence is the highest. Regarding treatment, the treatment is available free of charge to all the patients. Right now, it's accessible for viral hepatitis B among the infectious diseases specialists, but for treatment of viral hepatitis C can be conducted by not just infectious diseases doctors, but every trained doctors, also pediatrician, family doctors, and narcologists that can also provide the services on the treatment of viral hepatitis C. Patient pathways on viral hepatitis C. And then here we are trying to reach the world standards, international standards, and are simplifying the access point for the patient treatment. For example, the patient without the special indications, they can also receive the services and the diagnostics and treatment on the simplified patient pathway or flow chart. And patient entering in the system because of the screening. Screening is accessible because of the rapid tests, meaning the result of the testing, the patient can get in the side of the room of the patient throughout the 10 to 15 minutes that it takes for the test to process. I guess this is one of the most accessible form of services and one of the shortest patient pathways, where the next stage is confirmative diagnostics that can be started at the same day if the screening has shown a positive result for a specific person. The sample taking can happen in the hospital where this is possible, where the screening services or the preventive diagnostic services is accessible, and those samples can be delivered to this CDCPs and that are conducting the testing themselves throughout the 2 hours or 24 hours. The results can be received by the doctor that has referred those samples or the patient himself to his email. If the result of confirmative diagnostic is positive, then additional testing is conducted that are accessible within the program for medical guarantees and the ambulatory package of services. They don't require significant time periods for testing. A lot of them can be conducted by the doctor inside of his room, but for example, viral hepatitis B testing, access to treatment. After receiving all the results, the doctor can, in the shortest period of time, prescribe treatment, and treatment is not prolonged or long-term. The access to treatment is accessible because the government is procuring free of charge medication for the patients. This is effective medication that are in 95% of cases are giving an effective result, and the patient fully recovers. Therefore, to prescribe the treatment right now, we don't need expensive testing on genotyping because the medication that are being procured by Ukraine, they are accessible for all genotypes of viral hepatitis C. They are goes for any type of genotype, and especially there's no special testing or attention is not supposed to be given there. The only thing is the duration of treatment can depend from 12 to 24 weeks depending on treatment, which is 3 to 6 months for treatment, which is the short regimen for treatment that don't have any significant contraindication and that are accessible to the patient and does not require a significant amount of attention and monitoring from the side of the doctor. At the same time, despite approving as the priority objectives on combating viral hepatitis B and C, we still do understand that there are barriers and restrictions that are in place. For example, we have significant fragmented disruptions on terms of data retrieval for data that would be needed for policy building activities. We don't have a unified data system or a unified registry for all of the patients that would have been detected or that would have the screening results as a positive or as a net positive. And we understand that on the stage of the making the diagnosis, this data collection system is not perfect. All of that influences the decision-making process. So we can't really track to which extent the program is effective and in which way do we need to develop, change, or improve. At the same time, the understanding of the data are not sufficiently filled with needed indicators. We also know that there is a need to further integrate the services because what we are seeing so far is that the biggest prevalence among the patient of the socially significant diseases. And so we do understand here that the co-infection of viral hepatitis C, B, and HIV and TB of patients with dependencies or addictions or substance use disorders, they require additional attention and special list of research and additional attention to this patient. We also understand that for us, one of the priority and the government is one of the objectives to fighting the barriers in terms of the access to confirmative diagnostics among the general population and not just among the key groups. At the same time, we also understand that the access of pregnant women to services and the program for combating viral hepatitis B is one of the priorities of both the government and WHO, requires additional assessment and understanding the patient pathways, the understanding which stage the patient can actually be lost to follow up, and also to understand where the services and prevention are not sufficiently presented, where this is the matter of both the access to care and prevention for mothers and also an ability for a timely prevention of diseases in the child and the person that we have to take right now when the full-scale invasion is happening. At this time, I'd just like to say thank you for your attention. And we want to say thank you, Irina. See you next time. Dearest friends, we would like to invite to the stage Irina Ivanchuk, the head of the Department of Management in Combating Opioid Dependency and Viral Hepatitis, CIS, and Public Health Center, Ministry of Health of Ukraine, was the presentation will be dedicated around the topic of detection, diagnostics, and treatment of dependencies, substance use disorders as well. The previous speaker has laid out how well the patient pathway is being developed, and I'm just like to point out about the joint topic that really is needed for all of the conditions, and then the issue that frequently obstructs us to effectively involve patients for treatment and leads to losing patients are in the stage of the screening, diagnostics, and treatment. And this is the dependencies and mental health disorders. And here in the slides, it's shortly a simplification pathways, the stage of the screening, inclusion to treatment, and then retaining patients in treatment, and then this joint to oral anesthesiologists, and how mental health and those substance use disorders and dependencies and addictions are leading to the disruption and retention of the patient. Regarding screening, we know the mental health disorders and the dependencies or addictions that are significant mental health disorders. And even though the Ukraine is actively moving in the buildup of the services for mental health, stigma on the separate disorders is still staying in a big and sufficient matter. And so we had such a normalization to an extent of some mental health disorder. It's not such a shame to have. We are actively speaking about depression, anxiety, PTSD, but there's still conditions that are less spoken of and that are still stigmatized. For example, those are addictions, and then here the big judgment on this is your choice, this is your personal decision, therefore there's a lot of stigma regarding this. And people that have those disorders, they're much more rarely reaching out to the health system, and much more rarely the screening is conducted for them. The second part, this is also connected with the misconception or bias. People who have the mental health disorder, they have a lot of somatic disorders, psychosomatic disorder, and doctors are under assessing somatic arguments. They're just saying, oh, it's psychosomatic. And then the use of psychoactives, then they're decreasing the vigilance of the person to somatic symptoms because they think that this is the abstinence syndrome or acute intoxication, and then we're losing a lot of people. We're not screening a lot of people, and we're losing them under and not following up to the diagnosis. When we're speaking about the diagnostics, and then regarding treatment, and then retention in treatment. Regarding the mental health disorder, we do understand that right now one of the mostly spread, which is depressive disorders. And then depressive disorders, they are connected with the feeling of loss in any hope, not seeing your future laying ahead. But then the person that has such a concerns, they're not really motivated to be involved into the treatment and to make this treatment available for them. And then in this context, it's really hard without solving the matters regarding mental health to treat a person by using techniques for the motivational interviewing before we are solving the matters of comorbidity for them. And the second thing that we know, that some of the mental health disorders and conditions and the use of psychoactives for the patient, they can actually cause an induce of mental health disorders themselves. In depression, we also know that about the transitory cognitive disorders, also alcohol use causes the mental health conditions and disorders. And when the patients are coming to treatment and practice, this really influences the ability of the patient to perceive the information that is trying to be described by the doctor, to retain the information that is being described to him by the doctors, to hold the point presence of attention, and then to consider and follow up the doctor's orders. And then it's harder to work with such a patient. This complexity is connected with the cognitive disorders being caused by the mental health disorder, or there's the use of psychoactives. And then we also understand that the use of psychoactives, and then it's all encompassing that it changes the dominance, and then looking for the substance and not for treatment. And then the motivation for treatment is being decreased because the priority is looking for the substance that to reduce symptoms and not looking for a solution. And also for the mental health disorders and also for addictions, what can happen is that you can't really do impulse control, and this is not that just it's a bad character, but this is neurobiological grounds, and then accordingly our patient can not follow the treatment regimen and is more so impulsive, risky behavior prone. And then by summarizing, this is also about that before we have a full understanding of those specifics of how mental health disorders and addictions are coming along and how they influence your patient, we'll be losing patient in terms of the retention and care, because this is one of the leading factors of loss to follow up and within the cascade of treatment for those patients. And this is why you can also see This is the data for the research, how frequently we are facing mental health disorder, alcohol use disorder, psychoactive use substance disorders, and HIV infection, TB, and viral hepatitis. The data for the research can be a bit different, but yet again, you're seeing the significant numbers. For example, if you're speaking about the alcohol use disorder, this is around a third of the patients that are having such a disorder. This is a significant number, and this is a disorder that is really ignored or widely ignored. And then a separate part that I would just like to mention about the comorbidity, when we are starting off to work with dependencies and mental health, and then among our patients with different nosologies, what we are facing is that we are picking to work with the patient with just a mental health disorder, or we're just implementing OST, and here we are ignoring the complex nature of the double and both sides comorbidity. And we can see in the data of the big population of research and survey, there's links for them. Around 30 to 50% of patients that are having mental health disorder, they also have substance use disorder, psychoactive use disorder. And here it's important to understand this complex interaction, interdependency of this comorbidity. And if putting it simply, then it can happen in three typical areas of work. And those areas of work is helping us to decide upon the future treatment. Then the mental health disorder and then the substance use disorders, they can be faced in the same person alone, and then can be connected with the use of the traumatic events as a factor, and other factors, and also going through trauma, mental trauma, increases the risk for mental health disorders and also substance abuse disorder. And then therefore there's these two independent disorders that have to be independently treated according to the evidence-based approaches. And then therefore the second part, which is when we understand that the use of psychoactives it causes the mental health disorder. And we know that around for 50 to 70% of all the people that are using alcohol, they have the alcohol-induced depressive disorder that can go away in itself when they are stopping with the alcohol abuse. And then we know that prolonged alcohol abuse causes the anxiety disorder that even after you cease using alcohol can for some time can stay still in the patient. We also know about the induced use of methamphetamines or cannabinoids induced psychosis. And here we need to distinguish what is the primary thing and what is the secondary thing, so that we can use the correct strategy for treatment. Because if we are treating the person that has depression induced by alcohol and prescribing antidepressants and cognitive behavioral therapy, the best approaches for treatment without solving the main provoking factor, we are not reaching effectiveness in treatment, and our efforts would be laid in vain.
And the third concept would entail that sometimes psychoactive substances or PSAs are being used for self-treatment of mental disorders. And actually we see this more often. People with post-traumatic stress disorder can be using PSA and alcohol to solve the problems of depression. And there's a separate strategy. Actually, the strategy would be that to start with, we need to solve the problem of mental health, and sometimes the substance use disorder eliminates and stops. And this is about us introducing the interventions within either PSA or SUDs. No, this shall all be integrated into the HIV, TB, viral hepatitis services. And we have to understand the complicated nature of interrelation between all these disorders in order to efficiently and effectively manage them, and for this to be influencing the efficacy of the treatment. And on this slide, I'm not going to read it all, but actually we see the results of multiple surveys, and they show to what extent we can increase or decrease the indicators of treatment efficacy, the viral suppression, finalization of the treatment, keeping a patient in efficient treatment of TB if we treat, or we might not treat substance use disorders. This are very persuasive figures. So the issues of integration would not be just the issues of patients getting the services, but these are the issues of our HIV, TB services to be efficient and us be achieving our goals. And if to speak about about quite a simplified route of a patient, pathway of a patient. At all the stages of screening, diagnostics, and treatment, it's recommended that we have integrated approaches as regards early screening, early identification of key mental health disorders and psychoactive substances use disorders, alcohol use disorders. And there are simple structured tools. So the next stage would be identifying the response, depending on what kind of results we are getting on the basis of the screening. What's important here? Well, actually, the disorder and the SUD would not be working just in dichotomy. The intensity, the severeness of these disorders can differ, and majority of these patients either have got some slight disorder or moderate disorder intensity. If we don't conduct the screening in a timely manner, we might identify people at the later stages, and we have a distorted understanding that everyone who's got disorders have got very severe disorders. No. Usually this would be either early stage or moderate level, and they don't require highly specialized inpatient care. This would be sufficient to use psychoeducation, short intervention, motivational counseling, and further monitoring. These are all structured interventions any healthcare professional can be providing after training. And not only in case when we see high risk or severe symptoms, we do the referral for further psychiatric care. And summarizing it all, the screening, diagnostics, treatment of disorders and substance use disorders shall be an integral part of pathway of a patient. And in times of full-scale invasion, this integration is more and more important and well needed, because we see changes in the drug scene, we see new psychoactive substances emerging that are more addictive, that have greater neurocognitive influence, and then we get patients with cognitive impairments we need to know how to work with. And we see new categories of users and more shifts from the cohort of recreational users towards people who try to treat their psychological symptoms, self-treatment. They abuse medicines, and we have to take that into account. And there are simple, well-structured interventions that can be used by HIV, TB, viral hepatitis services provided, that are evidence-based and that can be easily trained. And for sure, interaction with the specialized care shall be ensured. Centers of mental health, for example, as well as inpatient psychiatric care. And to crown it all, I would like to mention the tools that are important. And they have to be cross-cutting for all the patients. These are the tools related to trauma-informed approach. We understand that majority of patients who have got mental disorders have got substance use disorders. Sometimes it's sexual trauma, childhood trauma. These are people who went through captivity, torture, and we need to know how to work with these people, not to re-traumatize them, and provide high-quality medical care. And these are the approaches of common decision-making, which include respect towards the patient, decent treatment of the patient, and selecting the best options of the treatment. Thank you. Thank you, Ms. Irina. Thank you. Very profound presentations, and they actually make us wanting to analyze it all. So we are preparing the stage for the comeback of our experts who were providing us with their presentations, not for some additional questions, but maybe for certain clarifications. And I would like to remind you about our QR code, an opportunity to ask your questions. This will happen. The questions will be asked if we have enough time. We are mindful of the time, but this shall not stop you from asking these questions, sending these questions. Also, we believe some questions might be repeated, so if we have time, we will be just asking the generalized questions, meaning those that were asked most frequently. So, using this QR code, you can find a chapter or section, Ask a Question, mention whom you are addressing this question to, and then possibly after the presentations and discussions, we will have an opportunity to ask that question. So I hope that will be the case. So, ladies and gentlemen, a round of applause to express our gratitude for the presentations. And let's continue with our communication. I invite Ms. Jana Terleyeva, Ms. Larissa Hetman, and Ms. Irina Skripka to join us at this stage. Oh, and for sure, Ms. Irina Ivanchuk, you left, so you come back to us, please, as well. And the questions are going to be asked by me. You've got the microphones, you've got water cups, everything needed. And if you need some coffee, mention this. But I don't think we will use that much time. My first question to Irina Ivanchuk. So, we've seen that mental health and substance use services are indeed crucial both for effectively engaging people and for retaining them in care. So, why are these services so rarely provided and integrated in practice into services related to HIV, TB, and viral hepatitis, if that's really so? Yes, thank you. I'm not going to be mentioning systemic barriers because we'll all know about them, but the key one is related towards the understanding of this problem. We still have this very stigmatized perception of substance use disorders, a complete misunderstanding that such disorders are not a personal choice. I'm always reiterating this, and there's this neurobiological component of the changes. So, we, whenever working with these patients, are seeing people not just with bad nature, but they have some biologically predetermined changes. So, I believe until we have a proper, correct, tolerant understanding and perception, we can be creating great standards, developing regulatory acts, but this won't be efficient. And let me exemplify using the screening. If it's enough to conduct some instrumental laboratory tests and we see whether the person has got infection, that's it. But if we speak about mental health disorders, substance use disorders, that's not that simple. It all depends to the extent to which a person who is communicating with such a client can not be expressing some judgment. It should be just a frank conversation between an expert and the person who is just basing their opinion on the information provided by the patient. We need to forget about judgment and we need to perceive every person as is, and only then we will create efficient services. I would start with this. And unfortunately, actually, sometimes we're using some discriminatory words like drug addict, alcoholic. You know, words matter, and these words already create a huge barrier between a person with a substance use disorder and the system they resort to for help. Thank you. Thank you, Ms. Irina. And my next question would be to Irina Skripka. Tell us, please, what factors have contributed most in recent years to expanding access to medical services for the diagnosis and treatment of viral hepatitis in Ukraine? Well, actually, we have achieved significant progress in this regard. For example, decentralization of services. If in the course of COVID we had 18 healthcare facilities that were providing services on treatment of viral hepatitis, we have more than 230 now. Significant decentralization thanks to screening. In 2022, a decision was made to procure, using the state budget, test systems on viral hepatitis, and now the network exceeds 1,500 facilities that provide these very services, and more than half would be family physicians that can start this pathway of a patient. Then up-to-date standards of treatment that meet the international protocols, international recommendations of the global associations on combating viral hepatitis. The standards, as we've seen, simplifying the pathways. We are oriented at the most up-to-date guidelines, and we reconsider our standards on an annual basis, as frequently as possible. And we are trying to integrate the services, for example, the screening services, into the programs of countering other socially significant diseases. The screening services are available to key populations, and we are directing more and more efforts on ensuring access to diagnostics for key groups of populations. Thank you so much. My next question would go to Ms. Larissa Hetman. What mechanisms are needed for truly integrated case management rather than just the formal referral of a person between different services? Thank you for this question. I will start with the pathway itself, the one we've mentioned repeatedly today, and we will be still mentioning it. The pathway is not just there to check the box. It's not formal. It's well agreed upon that meets the industry standards. But the pathway on its own cannot emerge just by chance. No, we need to make certain managerial decisions. We need to agree and coordinate at the level of one institution. But in majority of cases, we still need to involve multiple institutions and authorities. Also, this is the issue that pertains to those who are providing the services, meaning the services providers. This is the issue of human resources, their training and education, timely supervision, mentor support, and issues pertaining to data, exchanging data. Even at the stage of going through this pathway to avoid the situation when a client needs to repeatedly resort to the same service or use some extra actions, repeat something that was already done at the previous stage. And for sure, the issue of data about the services. That would be the key things. Thank you, Ms. Larissa. And Jana, the next question goes to you. What role do local communities play today in combating TB? And the second question, what successful initiatives to integrate services of TB, HIV, substance use disorders, and social support have been already implemented at the community level? Thank you. I would like to start with the fact that we ourselves need to reconsider the role of the communities, and that's important to understand that it's not enough just to have a successful and up-to-date TB center at the territory of the community. It's important to understand that a facility that can prescribe proper treatment might still fail to cover a patient because a patient doesn't have money to travel to this center. Then the pathway is broken. It's important to change the emphasis because if we speak about combating TB, the medical component doesn't play such an important role as is played by the comprehensive approach where the community has a key role. This is not just our vision. There are tools and there are mandates at the level of community TB because, the law on combating TB says that local self-governments can have certain programs of their own, but the key thing would be that the community understands not just what area is problematic, but people who have TB or HIV or addictions with what challenges are they facing, what barriers are they facing, and the programs shall be oriented at addressing these problems in an integrated manner. What's happening in practice? The first thing I'd like to mention would be that communities have to understand their own epidemiological situation. They have to understand where is the concentration of IDPs, what are the entry points of veterans, what are the complications, what can be done. Communities have to and can ensure accessibility, especially now it's important in the context of war. There might be various models that are being implemented today. This would be mobile services, mobile outpatient clinics, mobile drugstores, and sometimes it happens so that people just don't know what the situation is, whom to refer to, what are the symptoms, and some simple things as information campaigns can be one of the powerful tools that are being successfully used at the level of communities. Then integration of services around patients. We speak about this all the time, and we would like to proceed from words to practice when we change paradigm, not a patient wandering between various levels of the healthcare systems and other systems, but the services are grouped around patient. So one of the most successful initiatives that are out there would be the initiative of the community, Free from TB, initiative that's being supported by MOH, Cabinet of Ministers of Ukraine. Dear friends, we are monitoring the threat level and we will inform you what to do. This shall not stop you, though, from your own decision to go to the shelter if you feel like it. Yeah, so right now and today we're implementing a large-scale initiative, Communities Free from TB. Almost 200 communities joined, meaning communities are already displaying high level of awareness and readiness to solve certain problems. But what we would like to have, we would like to proceed from separate successful initiatives that depend on active manager of regional CDC, a community or opinion leaders to more systemic work that would cover the whole country, and for this initiative to actually be turning into the initiative Healthy Communities. We have such great examples in Lviv Oblast, and I would like to highlight that if at the level of the system we are creating policies, at the regional level we are coordinating for these systems to be operational, then at the level of the community, a specific person, a specific patient is facing the system, and they are either covered with our initiatives or the key role of the community would still make sure that all these pathways are operational. Thank you so much. You've mentioned the context of war, and I have a general cross-cutting question to each and every one of you. Could you give me an answer to this one? So, in what way war can influence the epidemiological situation, and what systemic decisions need to be made to adapt programs to these challenges? So, please share your expert forecast and one possible solution for these areas. Okay, let me start. I'm not going to be forecasting anything really specific here, but the situation that we witnessed today on decreasing the incidence, identifying new cases, and on decreasing the number of people staying in the inpatient facilities that are covered by the ART as the significant factors of actually covering them properly. There are plenty of factors influencing this that are related directly to the war, to migration of the population, and a lack of data from the temporarily occupied territories, and response of a certain oblast, certain region to the epidemics, which is why actually we need to, I believe that this situation is going to be clear when we bring back our occupied territories, when our citizens are going to go back to Ukraine, because even today, according to the data which the PHC has got in its hands, more than 10,000 people who were covered with this type of care left Ukraine, moved abroad. So it all will depend on many components, including on prevention programs and the testing programs, as well as some other important components. At the very same time, we need to have a finger on the pulse, and we need to have the issues pertaining to HIV infection under control, the issues that pertain to integrated services, because the war changes the landscape of everything, unfortunately. And it touches upon the socially significant diseases, and no doubt that's difficult to give any forecasts as of today. And actually, speaking about the socially significant diseases, yes, forecasts would be something difficult to deal with. And we are people, we are human. We would like to at least understand some more or less close horizon. Maybe you can give us your answers, Miss Irina, Miss Yana. Well, if to speak about substance use disorders, there are plenty of data in the world that tell us that in times of wars, societal crisis, the problem of substance use disorders increase. And we see it based on the data collected by the PHC. And actually here, if we speak about mental health, then again, there might be various reasons for the increase, maybe due to the traumatic reasons, sometimes due to somatic disorders that are related to the head injuries, brain injuries. There are plenty of those, and they lead to certain psychiatric and mental disorders. So for sure, we expect growth. If to speak about solutions, I will tell you one. It's related to strengthening of the HR potential. For sure, we need to introduce what I've mentioned before, the mental health services, the substance use disorders awareness among all the healthcare providers. And second of all, what we speak about substance use disorders and mental health would be peer-to-peer support and socialization of this approach, because we've got rich experience in Ukraine on peer-to-peer approach, but this area is not yet institutionalized as a separate professional activities that shall be based on the professional training approaches. And the component that had been discussed for an extensive period of time, that's related to substance use disorders and addictology. We see this based on the experience of other countries, namely such professions would help dealing with these problems. I believe tomorrow we are going to discuss this. Yeah, I believe we are going to discuss this. Okay, so if to speak about TB, wars always deteriorate the situation, worsen the situation, but I'd like to really abandon the practice of the forecasts, because here we need to be aware of the number of the clients and some other data, but we need to understand what the war is influencing in the first place. So now people are coming to us in later stages due to various barriers. And in such complicated conditions, people have higher chances of putting their treatment on hold, and they lose hope sometimes even for tomorrow. So in this condition, it's difficult to stay in the system. Next thing, that drug-resistant TB can be going up, and that's also interrelated with the first two reasons, where there might be reservoirs of undetected infections, or people who stop treatment create new opportunities for this infection being contracted by others. So the system shall be adaptive, flexible, and introduce new models and new approaches. And I'm sure that sooner or later we will combat TB. You are very optimistic, and I believe that's great. That's an example for the whole planet. So you agree? Well, I would not give any forecasts as regards increase or decrease of viral hepatitis. We understand this would be diseases that are transmitted via blood. They are bloodborne. But we understand that in civilian sector and military sector, the risks are increasing, and there's huge load on civilian infrastructure. But still, we are achieving certain goals: accessibility of treatment and speed of identifying the disease actually helps us decreasing the number of new cases. So I don't think there might be a forecast for the nearest years until we get out of this war, until we have sufficient human resources, accessibility of services in the sites, within the sites closest to the patients. This forecast won't be efficient without that. Okay, what can I tell you, dear friends? These answers make us sure of one thing: we need to continue working, and this is the only thing I understood: to work hard. We've got goals, we've got understanding what to do, or sometimes if we don't have an understanding what to do, we still have the second day of discussions. So far, I don't see any further questions to you. This tells us either that your answers were sufficient, or what else? That, well, in general, there are no questions. All the issues, the questions were answered, and we can proceed to the next speakers. Thank you so much for spending your time, for being with us here, and we are going to have a break soon, but not now.
I would like to announce that the transfer for the next part of our discussions, and which is referring to international experience. During the next line of discussion, we will move from research from the national experience to global context, and we are leaving the chairs here, and we will be discussing the European integration from the point of international partners. And we will research what of international experience Ukraine can adapt for itself. We will hear out how the colleagues are perceiving the readiness of Ukraine for the European integration in health and TB, HIV, and viral hepatitis. This discussion will be following in English, therefore I'm kindly ask you that we do have interpretation simultaneously provided to you. And right now, those of you that want to listen to a professional interpretation to Ukrainian can use your headsets and then select the language of your choosing and to listen to not miss a thing from what is being discussed. Therefore, I will remind you about the ability to ask questions using the QR code. And now I will present the participants of the panel discussion that will be happening in two formats, as both in physically present of speakers and also those of us present online. Therefore, dearest of friends, I'll present to you all of the participants of this discussion. First of all, which is the Anastasia Ferris, the principal expert and the group leader on SDG targeted diseases from the European Center for Disease Prevention and Control. Also, Ilse Jacobson, the principal coordinator of EU4MD second project, International Cooperation Sector Partnerships and Innovation Unit, European Union Drugs Agency, in the support of innovation of the European Union on the drugs and everything else. And also on this stage, let's welcome Leonid Krishchenko, HIV and hepatitis B officer in the Service Delivery Unit of WHO Country Office in Ukraine. Please do take your seat, a comfortable space for you. And also, well known to you, Pamela Foster, the Health Program Manager in Health of Coordination Office of Assistance of the Embassy of the U.S. to Ukraine. I will be moderating this talk as well in English. Therefore, yet again, I'll remind you about the headphones, and therefore we can. And we have Anastasia Foster and Ferris joining us online. Thank you so much. We do see you. Can we check if we can hear you?
Sound okay?
Hi. Shall we see Anastasia on the big screen? Anastasia, hi. Do you hear us?
I do hear you.
Perfect.
Sound okay on my side?
Could you please say something, because we don't understand if we hear you correctly? Say hi.
Yes. Good morning. Hello.
Як чути, друзі? Мені здається, що трошки...
Can you hear okay? If there's a delay, let's check for that. But we can continue, don't stop. Okay, so I think that technically saying we are good to go. Wonderful.
First question is for you, Anastasia. Communicable disease surveillance and data sharing are an integral part of European Union legislation on serious cross-border threats to health. What is the European Center for Disease Prevention and Control's view of Ukraine's surveillance system capacity? And what should Ukraine improve first, on your point of view?
Thank you so much. There are a few slides. I'm not sure if you want to put them up on this side. I can share, but it's disabled. So let me know what you prefer. I can also speak without them. What is best?
Could you please share the screen with us?
For now, it doesn't let me share the screen. It's disabled.
We need to see a presentation. If it's possible, could you share?
From this side, not possible. Now it's okay, yeah.
It's a little bit not okay for us.
I think it's coming, but slowly.
Okay. One more time, you mean to share? Could you please share the screen with us? We'll fix it here technically. Could you please do it again? Hello.
Okay now?
Yeah. Is it?
From your side, can you confirm if you see any slide?
That's how we can see it. Yeah? It's okay? No? Actually, we can see it on small screens.
Okay, so sorry for this.
In a few seconds we can see.
Better?
Yeah, you can continue, Anastasia. Thank you. Yeah.
Okay, sorry for the technical difficulties.
Oh, yeah, it's okay. Thank you.
Thank you so much to all the presenters. Thanks to the panelists so far. It was really interesting, and it's nice to see some friendly faces on this panel before. as you introduced, work at the European Center for Disease Prevention and Control. We're based in Stockholm, and we're an EU technical agency working on communicable disease. So my team works on HIV, TB, hepatitis, and STI. We also have a lot of collaboration through a project with DG INIST with Ukraine on exceptional support, and I'll mention this a bit. But on the issue of the surveillance system capacity, myself and also many other colleagues at ECDC have had a chance to look at Ukraine's progress in this area, and we have been impressed. And so I think that's what I want to start by saying, is that you have continued surveillance. This was mentioned already in the last panel. During a situation of extreme difficulty during war, surveillance of communicable disease is ongoing. I know it's more difficult, but that has continued. So you have very good foundations in this area. You also have good legal basis and growing analytic capacity, actually, which is extremely impressive, and especially your use of AI. And you have started to integrate some of the European observers in surveillance networks and data sharing, which I'll come back to. Some colleagues at ECDC had a chance to do a review of the clinical disease surveillance in Ukraine last year, and it was published earlier this year, the report, which is online. And they looked generally not only at the areas we're discussing today, but found that there were a lot of really good basis to be done. But what is, I think, the main area that I'd like to say, and I think this has already been highlighted a bit, is making it more interoperable. It's kind of the key word for many people working on surveillance today, and it's extremely important. This is the way of the future. And so these areas where we know that patients need to have integrated care, and we have discussed this for many decades, how do we integrate care for HIV, TB, hepatitis, mental health, and substance use at the patient level? How do we also integrate the systems so that we have a more interoperable experience there? And so this is, I think, one area that would be important for integration. And this is a lot of possibilities now going forward, including with more health records and use of AI in the health records. Ukraine is already implementing this, but also making data more rapidly available and actionable for policymakers so that it can be used to make decisions, prioritize, and rapidly respond in situations where that's. And then sort of say three priority areas for EU integration. The first would be this area of digitizing. So this report that was published highlights this a lot. So you're moving in that direction towards fully digital systems, but trying to make them more interoperable and connected, while also, of course, paying attention to patient confidentiality and integrity. And this is something that is the experience of many EU countries also, are on different points in that journey towards interoperability. The second area, which is important for Ukraine for integration, and it's really a high priority for many EU countries, is this integration of laboratory data. More and more, we're using laboratory data in public health, molecular surveillance, and so bringing that data into reporting and surveillance platforms. That's also something that is an area for growth, and is something that I know is already being worked on in your country. And then finally, with other European countries in real time. So both within your own country, improving the timeliness of data availability, but also increased participation in the European system, which already Ukraine has access to for some diseases. That could be expanded. So this is a system called EpiPulse, where ECDC coordinates the surveillance of infectious disease and report in a standardized format. So increasing the participation into the EU network on disease surveillance. And we've had really excellent experiences having colleagues, Larissa is one of them from the last panel, attending the meetings that we have, bringing all countries together from Europe to discuss issues on this, specifically on HIV. We'll have a meeting in December, deepening participation in these areas so that we can learn from each other and increase. So I think I'll leave it at that. Thank you very much.
Thank you. I go straight to my second question for you. Where is Ukraine succeeding? regarding data systems for HIV, TB, hepatitis, and sexual transmitted diseases. Where are improvements needed to strengthen surveillance and integrate services in these areas?
Okay. So Ukraine is doing a lot of things really, really well. So I'll mention that, but also focus on some areas where we can see room for improvement. Some of this came up already, but you have really good monitoring systems for HIV and TB. So you have those building blocks. You have learned from, especially in exchange that we've had on HIV for many years, as well as TB. And this has continued despite during wartime. Your systems are so strong in these areas. You have some specialized systems to build on for laboratory and information, so that's excellent. And you are also, we have seen good examples of this, as I mentioned earlier, for example, with AI. Also in the last question, that you're already participating in some of these European networks, so this is great. So maybe looking forward, what I think we should like to see more of is this is not only Ukraine. Countries in Europe are trying to siloed disease specific systems to more integrated. And this is both in patient care, but also in the way that we look at disease data. And so moving from these silos of a strong TB monitoring program to build where those systems can connect if possible, so that rather than strengthening in one area, that we sort of strengthen the entire thing. This is especially important for hepatitis and STI, where the data systems have been less strong in many European countries. So that experience is important. Secondly, moving from just thinking about the collection system, we need to collect data, report it, to more using this data for action, data for intelligence, and having it be timely and really tailored to the needs of decision makers, clinicians, many of you in the audience. What do you need to do your work better, to understand if your efforts are working? So having that linked in that approach. And then a focus on care continuity. And this came up a lot already this morning on the patient journey. And this information should be supporting the patient's journey and not only to provide statistics to support, but really support that journey. One of the areas that is highlighted a bit here is experience in PrEP in Ukraine. So this is data that we collect in ECDC monitoring, and it's about the number of people on PrEP. It's a bit old, it's the updated numbers, but I'm showing this to illustrate that Ukraine is among the leading countries, data from 2024, and has continued though, in terms of the number of people on the prophylaxis for HIV. So by the European standards, like, you have been performing really well and have put a lot of into this area. I mentioned PrEP though because we can also think a lot about this prevention modality. It's a good case for it. Has allowed and is allowing opportunities to look at HIV and STI prevention and care in one system. Continue to link the data together. It provides a possibility for hepatitis screening, for vaccination, for hepatitis B and other infections, for harm reduction to be raised with patients. And that's both a patient integration for the care, but also the system. It's a wonderful opportunity to integrate all of it. So I just wanted to raise that as something that I think you're doing, and also something that can be built on in the Ukraine system as one example today of where we look at many disease areas intersecting. Maybe also worth mentioning, Ukraine is one of the best countries in Europe in terms of women on PrEP. Proportion of people on PrEP who are women. A lot of your EU countries to that equity consideration. So just to end, I think that it's really important to think about this person-centered pathway, that the data follow the person, and that it really be linked for the entire continuum of care. This is applicable for all of the areas we're discussing today. It's applicable to mental health and use. And so using what systems that you have and trying to really focus around the person and connect those in a good way. So that's my overall message on that question. Thank you.
Thank you, Anastasia. Thank you. And please stay with us for further discussion. And we go straight to another speaker who is also online. So please welcome Ilse Jacobson. Can we hear you or see you?
Good afternoon.
Principal Coordinator, European Union for Monitoring Drugs 2 Project, International Cooperation Sector, Partnerships and Innovation Unit. Hello. Hi, Ilse. Do you hear us?
Can you hear me?
Could you please say some words again?
Can you hear me?
Yeah,
I can hear myself.
we can hear you too, so it's match.
Good.
Do you hear me?
I do hear.
Okay, thank you. So, drawing on European Union experience in the field of drugs and addictions, in what ways can this uniform Ukraine's national reform processes, and how can it be adapted to the Ukrainian context?
Good morning once again, dear colleagues, dear friends, because I'm sure that there are many of those who we met already before, and thank you very much for inviting the European Union Drugs Agency to this very interesting debate. Well, to start with, I would like to say a few words about the European Union Drugs Agency and what it does, because we are a relatively new agency, because before we were known as a European Monitoring Center for Drugs and Drug Addiction. So we are a decentralized EU agency, and our overall goal is to contribute to the European Union's preparedness of drugs. So do a lot of the things all around the drugs, but historically our background is monitoring of drugs problem. And that includes the polysubstance use. I heard a lot discussing about this before this meeting, even on the also solutions or responses applied to drug-related problems in Europe. In the same context and based on data, we develop and promote evidence-based interventions and best practices and provide research and support both on health-related issues to drugs and on drug markets and drug supply. So we operate how? We work with national focal points in each of the EU member states. We host the European early warning system, which has a national focal point as well in each of the EU member states. We issue alerts. We host a European drug alert system. This is a new system when we issue alerts on high-risk substances which appear in the market. We manage a network of forensic and toxicological laboratories. We also cover drug policies, maintain wide international cooperation. In this respect, I would like to acknowledge our long-standing cooperation with Ukraine. We have a working arrangement established with Ukraine and our Ministry of Health, and our partner in Ukraine is a national public health agency. So we work with them very closely on various aspects related to the EU accession, and mostly on the National Drug Observatory and on the national early warning systems and national monitoring systems, So going back to your question on EU experience, how the EU experience might help, and how practically EDA could help for you in the reform process. So our agency offers standards, offers methodology for monitoring drugs and drug-related harms, on collecting data on drug treatment provision and access, on monitoring drug-related infectious diseases, and developing early warning functions. As already by my colleague, DC, in many of those aspects, actually, we cooperate with them very closely. And this comes specifically on the monitoring of drug-related infectious diseases, where we have a common protocols in place and also share the data regularly. What these tools does, they help the countries to devise their national information systems. It generates a comprehensive and a comparable view on drug situation. And then you can use this data and information for your policy, preparedness, and service planning. So what our experience shows that these protocols only matter if they become an operational means at national level. So that is very clear who collects data, who validates, how information is shared, and how it informs decision across health, social, public safety, and community services. I know that tomorrow you will discuss the electronic systems and data, and I already heard previous speakers a lot referring to data, and actually data systems in place in Ukraine are very well developed. However, I still wish that when you start designing, implementing, and rollout of your systems, you also look at the protocols. For example, treatment demand protocol can offer you opportunities to introduce relevant indicators and definitions for monitoring drug-related infectious diseases in the specialized and non-specialized treatment for drug addiction. Drug-related infectious diseases protocols allow introduce specific also variables in the monitoring systems when it comes to the drug use in the specialized infectious diseases monitoring systems. There are also data needed for treatment coverage and accessibility. So if you take these protocols into account when you devise the systems from the beginning, it's sure that you will ensure the comparability of definitions, and it will make much easier the further alignment with the EU reporting. However, I would like to stress as well that besides the data monitoring, we work also on the best practices. And here, one of the things which was not mentioned by my colleague from ECDC, but I would like to stress that in the context of this particular meeting, it might be important for you to refer also to the guidance material developed together with ECDC on prevention and control of infectious diseases among people who take drugs. We had an update in 2023, and also European toolkit launched to help eliminate viral hepatitis B and C in prisons. These are the guidance documents which you can then adapt to national realities. And I would like to say that at least for some of them, there have been also input provided by experts from Ukraine in the process of their development. And now my second point is that these EU models, which we are showing to you and we are able to show you, perhaps cannot be copied mechanically. You can draw on this experience. You take the protocol, you take the guidance document, but as it was discussed in previous session, you have to lead this adaptation and implementation so that solutions fit your institutional settings, your region, your needs of the communities and the service capacities, and as well your current operating conditions. And from the side of the EPA, they are very much committed to support this process through the capacity development activities, through providing access to different networks and also peer learning as much as possible. And here we work very closely, as I already said, Ukrainian Public Health Center. So thank you very much.
Thank you, Ilse. Thank you. I have another question for you. What lessons from previous European Union accession rounds are most useful for Ukraine as it strengthens its drug policy, monitoring and addiction response systems?
Very difficult question because I think all the accession processes are very different. However, if we can say a few points, I guess that one of the focuses on the EU accession is usually perceived as a very legal and administrative exercise. So aligning the policies, strategies, laws, action plans, they of course are very important. But more important, I think, in the field where we work is that we create functioning systems which function in practice and which prioritize the needs of the people who need the support. And this means, investigating early in coordination, in data quality, and implementation capacity. And one of the common difficulties is a fragmentation of the services. I know that you are discussing today a lot how to minimize it, but in many countries there are separate systems for drug policy, addiction treatment, HIV, hepatitis, tuberculosis, mental health, social support, and even criminal justice. So they are developing something separately. They are not communicating between themselves, but people with overlapping needs. And I think we saw in the previous presentations, people who use drugs, they have a mental health problem, they have infectious diseases. So they have a lot of the need. And fragmentation might create gaps, delays, and missed opportunities for care. And second lesson is definitely that comparable data and clear institutional roles are also essential from the beginning. Monitoring systems and all indicators are useful only when institutions agree on definitions, on data flows, on how they validate procedures and feedback even on the data submitted to, because the data we are not collating just for the data itself, but to improve the situation of service provision. And the third lesson is to build the professional capacity while aligning the policy. Changing the policies might take a time, but invest in the people, in training, in strengthening also national networks, cross area cooperations, and creating these routine cooperation mechanisms already in place. So, in a short, EU alignment is not only about the right texts in place, it's about the building drug policy and addiction response systems that are evident, human rights-based, people-centered.
Thank you. Thank you, Ilse. Thank you. So also please stay with us. And we go back to the stage, to Kiev. Leonid, coming to you, I also have two questions, but starting from the first. From the World Health Organization's perspective, what is the role of primary health care in the provision of integrated care? And which services require coordinated action among different stakeholders?
Okay.
Do you have your microphone on? Try.
Let's try. Oh, okay, thank you.
Thank you.
So from the WHO perspective, I suggest that we start where we are in the terms of primary health care in Ukraine. So here's my first slide. We've prepared a few of them. So first of all, the primary health care in Ukraine is accessible, resilient, and digitally oriented. And I think the most important, it is acknowledged by the overall Ukrainian population, which is confirmed by various WHO and our European colleagues' assessments. Most of the people know where the family physician is located and his phone number, which I think is very good. Also, if we're talking about the role of the primary health care in prevention of HIV, tuberculosis, and hepatitis, what we see is that, first of all, you can get tested on HIV, viral hepatitis, and tuberculosis screening at the primary health level. Also, you can receive vaccination against hepatitis B at the primary health care level. And also, starting from 1st of September, you can receive treatment against tuberculosis at the primary health care level. But we have a few problems. First of all, the level of TB screening, as it was mentioned before, only 10% of those people who require screening against tuberculosis actually get screened. As for the HIV testing coverage, only 3% of people with so-called indicator conditions get tested on the HIV, which means that the remaining 97% of the people will be later diagnosed with AIDS, however, at so-called advanced HIV stage. And from our perspective, as a WHO country office in Ukraine, we continue to provide various technical and other support to our national stakeholders to overcome the situation, which includes, for example, our joint webinars with the Ukrainian Public Health Center. And if we're talking about the good example of integrated services, I think it is important to mention the prevention of mother-to-child transmission of HIV, hepatitis, and syphilis in Ukraine. And we need to acknowledge that, first of all, the system is coordinated and remain resilient during the war. Also, the level of mother-to-child transmission in Ukraine is below 2%, which is very good. And also, we have a national standards and protocol are in place. And from our perspective, we think we have a space for improvement. First of all, we need to strengthen the hepatitis B prevention. Also, it will be good to improve the early infant diagnosis and follow-up. And we as a WHO recommend maybe country could try to submit for EMTCT validation process, which means we're not asking to do it only for the sake of the validation, but because this process includes framework and path, and if Ukraine will go through this path, it will first of all allow us to improve the quality of the services provided to the overall population. Will increase the integration of the services of an HIV, syphilis, and hepatitis. Also, it will acknowledge the previous achievements, which are, I think, is good, and also it will approach Ukrainian service provision to EU and WHO standards. And I think it's over from my side for this question. Thank you.
Are you ready for the second question, Leonid?
Let's try.
Let's try. Effective integrated care is dependent on some important elements, including high-quality data collection and information exchange, as well as well-developed protocols. From the World Health Organization's perspective, what are Ukrainians' current achievements in strengthening those components of integrated care?
Thank you. And we have a few slides. So if we're talking about the reference laboratory quality, first of all, we need to acknowledge that establishment of national laboratory network and the resilience of the system in the context of the ongoing war. Also, we need to acknowledge that the modern diagnostic capacity is gradually exposed, even during the war, with great support from other international colleagues and with a huge work from our national stakeholders. And but there are some space for improvement, and I would like to compliment our colleagues from ECDC. First of all, we need to increase the laboratory confirmation of priority diseases, including tuberculosis, which means more rapid tests and more near point of care diagnostics. Also, we think that laboratory results should be linked to surveillance, and the paper-based reporting should be reduced and replaced with some digital solutions. Also, reporting and data. Here we see that, first of all, e-health infrastructure is established and functioning despite the war. We have a good disease-specific surveillance and reporting system in the country, and we see a huge collaboration between ECDC and TESI, which improves alignment with the EU surveillance standards. And here we also would like to compliment our colleagues from ECDC that there are some space for improvement, including report on to reduce the non-automated data collection, integrate the surveillance platforms to avoid parallel reporting, and strengthen the data quality and data analysis. Lastly, if we're talking about the clinical protocols, we have a good evidence-based protocols in our country, and which is very good. But also we have a space for improvement. First of all, we need to reduce the variation in protocol adherence between the facility, straighten the training of the healthcare providers, and expand the routine clinical audit. And we as a WHO country office in Ukraine, this is also one of our priorities. So we're working hard with our national stakeholders to support the dissemination and accessibility of the clinical materials to every healthcare provider in Ukraine, including digital solutions. And lastly, for example, we have a small slide from our colleagues from European AIDS Clinical Society, and they have recently developed the application which provide every healthcare provider working in this field with the latest data. And they are very easily accessible. Thank you.
Thank you so much.
You're welcome.
Thank you. Pamela? My question, the first one is, from the United States government's perspective, what has Ukraine already achieved in TB, HIV, and hepatitis that puts it in a strong position for European integration?
Great. Can you hear me? It's a good thing I took great notes from all of the presenters this morning, because I think we have a robust evidence base to draw on, right? There's been significant progress that provides a strong foundation, and this progress has been sustained in spite of the full-scale invasion. I wanted to highlight 3 areas in particular that I found many of the speakers pointed to this morning. So the first one is the modernized approach to infectious disease control, right? So in the HIV space, it's expanded testing and treatment, and a real emphasis on getting outreach and services available at the community level and at the primary healthcare level. I think for tuberculosis, there's been strong progress in a patient-centered approach with outpatient services and adopting much more modern diagnostic and treatment approaches. And then, of course, with hepatitis, the work to increase both testing and treatment and to integrate it with other service delivery approaches, I think, are all foundational building blocks. The second point I would raise is that this health system writ large has made great strides, right? It's not a disease-centered approach. It's about strengthening the entire surveillance system. It's about strengthening the laboratory capacity. It's about adopting and improving digital health tools, the procurement systems, and then the use of data to not only identify patients, but to monitor treatment and progress. And then all of these, I think, will allow Ukraine a continued sort of smooth pathway into being part of the EU health security architecture, right? And then I think for the third thing I would highlight that a number of speakers raised this morning is that it is not being seen as a health problem, right? It is a whole of government approach that is taking place in the context of other EU accession timelines. We see it with the regulatory frameworks, we see it with policy frameworks, we see it with the financial analyses to make sure that Ukraine has the fiscal space to make the investments and upgrades. We see it in increasing the technical alignment with EU standards. So I think that while there's always more that we can do, Ukraine is got a firm foundation and is well on pace, at least in the health sector, for EU accession. So well done, Ukraine.
So, as Ukraine becomes increasingly integrated into European Union system and financing, where do you see the United States adding their greatest strategic value?
Yeah, good question. I think that the partnership with Ukraine in the health sector, but in other sectors, will continue to mature and evolve. Right, we in the health sector are following Ukraine's lead. We are looking at our next 5-year period of cooperation and are changing the paradigm so that it's not also disease-focused, but focuses on how we use specific resources for HIV, TB, hepatitis, to strengthen laboratory capacity, to strengthen surveillance and outbreak detection, to strengthen the health workforce, right? So we are trying to follow where Ukraine is leading. I think that increasingly our partnership will be more strategic and targeted, right? As Ukraine matures in this space, as the EU comes more on board, you won't need bilateral assistance to try and help everywhere all the time. But I think by using university partnerships, building curriculum that are embedded in Ukrainian education institutions, and helping support the regulatory and policy framework, we hope to be part of Ukraine's success story with accession.
We also hope so.
Yeah.
And coming to our closing questions, I want to check if Anastasia and Ilse are still with us. If I can put them. Do you hear us, Anastasia, Ilse? Can we? Yeah. Ilse, do you hear me? So my last question to you is, beyond financial assistance, what forms of practical cooperation can we best support Ukraine's reforms in the field of drugs and addictions at this stage?
Well, thank you very much for the question. As an EUDA at the moment, we have a very limited financial support, which we directly provide to Ukraine, and all our funding strictly provided focuses to the support to the monitoring systems on drugs. However, we hope that we are providing some practical support in a different way. It includes also provision of the guidance and guidance document, access to the training, involving in EU-related networks, allowing possibilities for the exchange with the peers in the region. So this is this very practical opportunity which we are offering to our programs. What we see when we offer support, I think it's important not to be too general, and it's important to actually address the real problems or the real questions what partners might have. And in this case, Ukraine specifically, and within our mandate, for example, we really are targeting areas where we feel that we might be most useful and where we can provide the support and offer some solution to concrete issues or problems. And we frequently receive the questions, for example, how to organize the EU our development system on new psychoactive substances, where to start, how to address different new psychoactive substances emerging in the market. Recent questions include also how to organize or support for some clinical trials, the new drug treatment methods, how to also organize the drug treatment monitoring, how to open the new types of the services. So these are very practical type of the questions which we are trying to address as an EUPA. And I think that's the best way to work, is to address the questions which are coming from the country and where the needs are identified. I wanted to emphasize as well that as in EUPA, we are not offering only one model. So usually when we are offering the support, we are doing different models, because we have 28 EU member states, and in many of them, the provision of the care as well is very different, but the goal is the same. The models might be different. So we offer different experience. But as I mentioned in my previous responses, we rely on Ukrainian partners who attend the trainings, who participate in the study visit or the conferences, that they bring back this experience to their own country and discuss with the practitioners, with other leaders, and implement and adapt it to the needs of the country. And like the other people who spoke in the panel, I want to emphasize that actually there is a lot of the experience in Ukraine. We see also very useful experience for the Union from the European member states, especially in the areas of maintaining the services coordination and preparedness under the different difficult conditions. So also this experience is something what we are looking forward to receive from Ukraine for the EU. And I think we always emphasize that it's bi-directional change, because EU member states can learn from Ukraine and Ukraine can learn from EU member states.
Thank you, Ilse. Thank you. Thank you for sharing your time with us. Thank you for being with us today. And can we hear Anastasia? Anastasia, are you with us? Yeah, I also have a question, closing question for you. Which one area should Ukraine prioritize to show real progress to European partners regarding the integration of surveillance and data system?
Okay, thank you very much. I already mentioned interoperability, so I still think that's really important, and Ukraine should work in this area. But I think that with regard to sort of accession and collaboration across Europe, I think it's extremely important that Ukraine be very active in participating in these networks on HIV, on TB, hepatitis, and STI. Will be invited to the European network meetings, which take place regularly. A lot of activities, but also we have this grant from DG INIST for accession support countries. And so there we wait for Ukraine to come with specific examples. And Leonid mentioned, for example, the diagnostics. If this is something where you think you would like to have more exchange, maybe some technical support, those are things that can be proposed to ECDC, and then we can arrange either virtual or direct support possibilities, depending a little bit on your needs and what we can offer. And so I think be very active in proposing discussions, because we have seen at ECDC that countries have the solutions, but sometimes they need to share and sort of like see a new model, see a new example. And as I mentioned before, and it was focused on other countries in the EU can learn a lot from Ukraine. So it's a two-way exchange. So I would really encourage you to be very active, very proactive on asking, proposing, and participating in the data collection systems of TESI, which is now called EpiPulse, and as well as in our network. So we'll leave it with that, and thank you very much for the discussion today.
Thank you. Thank you so much. Thank you for being with us. Take care, Anastasia. We go back to stage to Leonid and Pamela. So, Leonid, which World Health Organization frameworks are the most applicable for Ukraine?
Oh, thank you. So, unfortunately, we have a lot of frameworks, and we have a separate framework for HIV, tuberculosis, hepatitis, and the good news that all of them already acknowledged and appropriated by Ukraine, and Ukraine following them, which is nice.
I agree with you. It's really nice.
And if we're talking about the integrated care, so there is no one way for every country. Every country have their own separate paths, and only thing that we can do is analyze their experience, compile all this information, and tailor approach which will apply to our country on the national or Gramada level.
Thank you so much. Ilse gave such a trend of long answering, and you're so short. It's different trends, you know. I like it. So Pamela, we go to the end. We're coming to the end of our panel, of our discussion. So please, could you tell us what is the single most important thing Ukrainian should do right now to make its program sustainable?
I thought I was supposed to get an easy question at the end. No. I very much hope that it is possible for Ukraine to maintain the momentum for EU accession, the momentum for the fiscal space in the health sector, the momentum for the health sector reform. I think the frameworks are there, the goals are there, the objectives are there, and there's just always the risk that other priorities press out what the great work that is possible in the health space. So I hope that it's possible to maintain the momentum, and then I think both sustainability and EU accession will follow.
So I just want to give a round of applause from our audience. Давайте поплескаємо, будь ласка, нашим спікерам.
A round of applause.
Your perspectives, practical recommendations for your ideas. Please continue to stay with us. This is the end of this discussion and session. Thank you so very much. Друзі,
Dear friends, and this is just a few dozens of minutes before the break, but you see that all the panels, all the presentations are important today, and this was just the first half of the day, and we will continue, and tomorrow we are going to have interesting discussions as well. So now I would like to ask you to concentrate on yet another presentation. We are going to speak about European integration process and what are the plans for the next 7 years, what are clusters and how can regions work with these clusters right now. So, we are going to speak about healthcare clusters, a person-centered approach and the possibilities for its implementation from Svetlana Kustova, an associate professor in the Department of European Integration Policy at Taras Shevchenko National University of Kyiv, an advisor to the Council of Europe, and a distinguished lawyer of Ukraine. Please, the floor is yours, Ms. Svetlana. Dear colleagues, give me a second for some technical details. Can you hear me well? We can. So before the meeting, I've prepared a short presentation. I lecture a lot, lecture to people of various professions, from customs officers to representatives of communities, issues related to European integration. Why am I doing this, and why is this my mission? Dear friends, you know, the thing is that I face this issue that European integration is considered and perceived as some formal procedure. And as of today, people with whom I start working, they don't clearly understand that we can do something here and now, that what can be gained from this European factor here and now. But I would like to mention that already now we have a lot of chances to really gain specific amounts of money to solve the problems. Well, for sure, I'm not an expert on the issues related to HIV or the socially dangerous diseases, but I know how to get money from Europeans, and our task here would be to really understand where to get this money from. For us to understand this, we shall not be considering European integration as a formal process of government, but we have to understand for ourselves what that is. So, if I may, a few words. I understand I'm limited in time, but if we don't understand the history, the philosophy, we won't understand in what way to communicate with Europeans. You know that within centuries at the European continent, there were plenty of projects related to creating some union, and the task of this union was ensuring safety of the countries that are part of this union. And you know, the EU, within its current philosophy, was created after the Second World War. And the question is, why after the Second World War? Because the founders, the countries' founders of the EU, decided to have a non-traditional approach, and they deprived themselves of an opportunity to manage the best segments of their economy. Second World War, Nuremberg process, and when after the Second World War, in the course of Nuremberg process and after it, Europeans were shown the How, Buchenwald, Auschwitz videos, and they opened their eyes. And the key task of the European community after the Second World War was to prevent something like that from happening, and that conscious desire to live in peace, to maybe compromise your own interests, led to the situation where this European Union was created. It was actually created under condition of fear. And, you know, when I talk to my students and when I talk to communities, everybody thinks that that peace at the European component that was there at least up to 2014, that was a must, something granted from above. But no, Johnson, an expert of one of the Stanford universities, he made calculations. Do you know how many peaceful days were there after the Second World War? 13. And that's just international conflicts. He was not speaking about the internal conflicts in the countries. And this is just the European Union. Why did it happen so? How come that they've created this union that ensured peace at the European continent for not a very extensive period? We need to say that this union was actually built on another philosophy. Philosophy of European Union is the philosophy based on the philosophy of helping a person, helping a private entrepreneurship, and the basis of the community would be a person, a community. Strength is in unity is the motto of EU, and we are related to that by the program of EU, by the policies of EU, and actually the peace on the European continent depends on this. The European Barometer, the Statistical Bureau of EU, demonstrates on an annual basis that the residents of EU trust the European bureaucracy rather than their national governments. And we got the EU. It went through the evolutionary processes. At first, it was an economic union, which is why we perceive the EU as the economic union. But Charles Monnet, the father of EU, said that the key drawback of his when he was creating the architecture of EU was the fact that it was based on economic issues rather than humanitarian issues. And actually, the EU started dealing with this values approach and humanitarian approach in 1992 when an agreement was signed and the EU was created in the shape and form we know it. Now a very simple question, going back to the clusters, what that is and how to deal with those and in what way we can use those clusters for our benefit, for the benefit of our community and for the benefit of people, those who suffer from these terrible diseases. European Union was a very specific union, which does not equal a state, a federation, a confederation. European Union is quite a unique union, which has got certain mandates. And these mandates of EU are stipulated in 33 policies: humanitarian policy, decarbonization policy, environmental policy, healthcare policy, consumers' rights policy, etc. So what these policies mean? They mean that members of the EU gave to the EU organizations, EU Parliament, European Parliament, well, 7 institutions of EU, mandate of solving issues within these areas and spent money on that. And I'd like to mention, when we speak about values of EU, that namely humanitarian policies related to people, namely coalition policy, the agrarian policy, are the most vital in terms of money. And in the recent years, the EU is actually making a turn towards humanitarian backed, towards helping people, helping communities. And the policies I've mentioned are united into clusters. So now we have a question, what kind of clusters are this and where did they come from? So these clusters appeared in 2020 within the methodology of expanding EU offered by Macron. And frankly speaking, dear friends, I'd like to tell you that this methodology introduced by Macron related to clusters was aimed at not a single European country to be able to join EU, because EU was financially unprepared to welcome any other country, but they couldn't say it aloud.
This is why a methodology has been established. Macron has the local election happening, and his specifics is that there is 15% of his electoral rate. This is farmers. And therefore, he needed to do something to close this European Union, and by the request of the farmers, and there was the methodology. But we have to live with this methodology. We need to move towards European Union accordingly. The point in this methodology is that so that those policies of the European Union that was just mentioned before, so the policy where the European Union has the upper hand, the rules of the game, and to fund it, then those relationships, they are merged into cluster. The first cluster, which is fundamental. Why is it fundamental? Because this is not just the rule of law related. Right now it's saying fundamental rule of law, but why this is so important, that the European Union, it's a union of an open type of union, and for us this is really important. What does this mean, the open type union? This means that the organization collects voluntarily so that to solve the most important deficiencies that they have, the deficit of resources and safety. But to solve those deficits, I'll get back to the presentation. I just would like to tell you so that everybody would understand this philosophy of the European Union and how do you need to talk to them. Why can't you say just give us money for something? It doesn't work like that in Europeans. And then to solve this the deficit of resources and safety, what we need to do, and I see that the timer is almost up, and so the participants of those unions would trust you, that are in the countries that are together with them in the union. And this is why it's very important to follow the principles and the rule of law, like court reform and judicial reform and rule of law, and then the existence of the European Union, so that this indicator would work into our end and to our advantage, and then we will be able to receive from the Europeans the support that we really need. As I mentioned before, that the 6 clusters, the fundamental, internal market, and we'll going one by one. And therefore, our main cluster, the cluster connected with the health, and then consumer rights protection and health, it's a part of the second cluster of the negotiation process. As of today, Ukraine has participated in the negotiation on the first cluster and on the cluster number 6, second, third, and fourth, and fifth. Hopefully, we will open this fall. But what does this mean to this negotiation process? What does this specifically mean that Ukraine entered the negotiation process? What is a part of this negotiation process? What do you think? How does de facto European integration looks like? This means, dear colleagues, that we have on each of the clusters or sections or subsections a list of laws, regiments, and bylaws and everything else that's needed. And so the negotiation means that we are responsible to giving those documents and then implementing them in our regulations. So we were giving a list. You have to approve the law on Section 1, Section 2, Section 28, and then we have to build them, and then you take them in, and then to conduct a reform. And then, therefore, for us, it's very important to move into the second cluster, and that considering the health. But and when we would be able to take all of the laws that are presented by the European Union, and then on all of those clusters, and then all of the countries of the European Union, and then making a decision, everybody's making the decision. We are in the European Union. For us, very important to get into the European Union up to 2028. Why is this important? Because the key aspects of taking Ukraine to the European Union, they can be shown by the European Commission and the European Parliament. And the European Commission and European Parliament, the election in 2029, and then the right parties are more likely will come. And the right parties can come, and the right parties are always the parties that are against it, widening or broadening the European Union. For us, this is very much needed. Every day, Parliament, cabinet ministers have to sit down, vote for, so that we would jump up to this train, we'd be able to reach there up to 2020. And then there's a question, why do we have to jump into this train, right? Or hit and try to reach this. Be more in detail. I did a description, but for us, what's important is that we have to receive from the European, and then not just after European integration, but on this stage of the European integration, the funds, and then to develop our issue and problems and everything else. And those capacity are also there. If you are to understand that to get those funds, we would need to understand their philosophy. The philosophy that traditionally is just working with other donors, give us the funds for procurement of the CT. This philosophy is not working with the Europeans. To receive funds from the Europeans, you need to tell them what kind of issue will be solved when we will be giving those funds. And this is why we have to get ready to those negotiations. This is especially Brussels kind of language, and then that we have to acquire so that to receive those funds, and then we have this level of importance, and then I will mention about this, why this is important. Right now we are moving to the presentation, and the main idea here is that the European integration in health, this is not just about care, about funds. And European integration in health is showing you the history. The European integration in health, this is the buildup of policies dedicated to the active response to the problem, but to the prevention, to solve this issue. And then where does the health system is created in our negotiation, which is cluster number 2, internal market, protection of consumer rights. And with this chat, there it is connected, the issue EU for health. The third cluster, the competitiveness and inclusive growth. The digitalization, innovation, human workforce, and everything that makes our hospital, our communities sustainable. The cluster number 4, which is the green program and interaction. So the energy of environment, logistics, transportation, climate, and then to solve the social significant issues and diseases that we are seeing, and then that we are all dealing with. And the 5th cluster, the most important one, the cluster of the resources, and then the policy for, and the well-established policy of European Union, because this policy is dedicated to help small communities to solve complex social issues. We can move on. As I mentioned before, why this is very important, to start studying what are those clusters and what kind of procedures they have. In other specifics, I would understand that HIV, TB, and other socially significant diseases, and because the EU funding, this is not donor support. Europeans are funding mechanisms. Europeans are funding policies. For Europeans, it's important to establish prevention. When you're saying that we need a tomography equipment, for Europeans, this doesn't really work. For Europeans, what will work is, what we need to do is, we have like an issue A, B, or C. Like an issue is diagnostics and TB and rural population. The Europeans need to say, and we have an issue, we can solve this, and we have the institutional capacity, we have people that can solve this. And then Europeans will give us funds for the project to solve something, to do something, and then yada yada. EU for health. This is the main issue of the European Union, word for word. And then why for us this is very important to have this EU for health and health system. Because without looking at 4.4 million euros a year, even though we are not a part of the European Union, in 2022, a European Commission started to help us and join us to the program for funding, and not even from the summer of 2022, but from the January 1st. And we have an ability to participate in competition to receive funding of our issues, and so to receive funding of those issues that are put in front of our centers and of our organization and so on and so forth. And then one history, and then there's questions I'll answer. And then any kind of European program, it's specifics of the European Union, and this is so important. They're all connected in 2 different addresses. About those addresses I mentioned before, those addresses where there is a list of tenders, documents, the examples of how those documents are connected, the support in having those grants, it's all of this. In the European Union, it's unified to as much as possible. And if you have issues, then you can easily, to those 2 platforms that I mentioned already in the part of the concept, to reach out and to look for programs for your issues. It's not just their practice, give us funds and we will do something for it. We have an issue, and each issue will be able to find a program, and then as possible unification and training. This is something the European Union put it to the highest of levels, so that with this instrument you can create it. And there are communities we are helping to write those grant applications as an option. There are communities that can use this. Dear friends, there are 2 additional projects, Horizon Europe, and that funds our projects as well, and also and the issues connected with the digitalization. And on those platforms that I mentioned before, and that are additionally consenting information, you will be able to find the list of those programs. For us, in the end I'll tell you, to safely use those capacities and opportunities of the European Union, and to make future actions. And you are making the main projects, the main justifications, or anything else, to look at how you can study them. And if you're working in communities, and then to reach out to your universities or anything, most of the universities, medical universities, they are receiving funding connected with the Erasmus+, and they can help you to prepare the methodology, coefficients, even the grant programs. For example, in Shevchenko University, there are also those departments that free of charge to communities within those projects is helping. So, and to look for funding for that. And this can help us a lot. And therefore, to any kind of before and after reading down, you can send us. I'll give it to all the participants of this respectable event. What kind of questions do you have? Dear Svetlana, to point your attention, because I'll be voicing. There's a few of them. What kind of EU program in 2026, 2027 will be the most high priority for Ukrainian charitable and other organizations? Thank you so much. And then, as I mentioned before about those 4 projects, and Horizon Europe, EU for Health, Digital Europe. So what is the point of an issue here? It's clear to programming in EU is for 7-year cycle, and unfortunately, even now, there's only a small capacity to reach into this cycle that has finished in 2027. This is why we have to prepare to the next cycle, 2028. A lot of funds, open programs. So right now, to do your homework, to decide upon the issue, the methodology, and then to the issue that you're reaching out to the European Union, and then in 2027, you'll be able to get funds for that. For any other programs as well, EU for Health and Digital and Horizon Europe, and then use Erasmus Plus. Because I'm saying again, the classical approach of any community to solve the issue, this is first of all an issue, then they're reaching out to your university, to their university, and then any community, as much as possible, receiving care and by the stakeholders, helping in the grant application, they're receiving those funds. Thank you so much. Question number 2 from our audience. Do you foresee that the EU sees the role of general public representing the European Union interest that offends social significant diseases within their support through the enforcement through NGO programs? Regarding NGO funding is one of the really important areas of work of the European Union within the first clusters. I would like to point your attention, not inclusion in NGOs or anything else to the process of the integration, put your integration process on the stop. And if you could see the reports in 2023 by EU Commission, that Serbia, Montenegro, they were not taken to the European Union. And for the Euro integration movement, and then there was no NGOs. For the Europeans NGOs that are working on the negotiation group on each and every cluster, this is the green light so that you can launch this process. If those organizations are not joining hands, then they're putting it to stop our movement to the European Union. Only positives, and then only support and funding, and the funding on the first cluster. The main components are inclusion and treatment, the positive and support. This is the 2 question. And I applause to you. Thank you so much. And the interesting thing, most likely connected, was the fact that when we had 4 speakers on this stage, if you remember, first discussion panel, then possibly there's connection to our international speakers, and then and the tablet, I haven't seen any questions so far. Therefore, to our respectable colleagues, there wasn't. But when we moved to the international discussion, then those matters started to give. And they are very interesting. They're interesting, and then I don't know whether there's a delay, but we've talked with our specialists. They're ready to answer to your questions at the end of today, so that we will get to all of the agenda, and then if you stay here and it will still be interesting, they will be responding to them. And then they are quite interesting. To remove our part, I would like for us to have a lunch break, have a nice lunch, and then I will wait for you in an hour on the stage with the continuation of our needed, and have a nice lunch. Thank you so much. We can continue. Thank you so much for everybody who's staying here, and thank you so much. And without further ado, we can continue. So please, let's use the QR code on your pages and the name tags and on the QR code on the screen. And then we'll play a bit. We'll play in the history modeling, which is the case definitions, and then you have just one answer is your option, where you have 90 seconds to answer. Therefore, this situation, and then let's wait for a bit. We got some food. You want to sleep. The night is coming, and then I'm just saying it with such a smile, but this is like from the mental breakdown and from exhaustion. There's nothing fun about that. But we are here. We are here to stay, and that you have to be staying positive. So everybody been there. So the situation is a person at the same time going treatment of TB, receiving ART as well for HIV, and opioid substitution therapy at the same time. The needed services are provided in a different health facility. A person is receiving a few referrals and are going through separate things again and again, and they're missing a part of the visits. None of involved experts don't see a full treatment plan or what this person has to receive. The question is, what kind of organizational decision has to be first and foremost to provide for continuity of care for them? In your opinion, please pick one of the options. To prescribe a case coordinator or case manager, to put the coordination on the patient pathway to a family doctor, and then to create a multidisciplinary team from the joint responsibility, or to organize the services receivable in this one health facility, or to provide for electronic exchange of the information between all of the involved parties and services providers. And the last option is to approve the unified patient pathway, to decide upon responsible people, and then the mechanism for coordination in case need be. A lot. And maybe it's going to be easier for you to decide what specifically you're an adept of and what would you recommend to others. Please select your choice. We will present on the screen the results. And we'll be moving to the question number 2. And the question number 4 of today. And we are actively working. And if somebody's with us online, even though by the experience of organized, they're saying that online people, they're preserving most of the viewers, not the viewers of the viewers compared to the offline format, but this is like an online. We are capable of doing so much more online. And we are being moving to the question number 2 or number 4, depends on how you look at it. And then the question is as follows. What in the patient pathway requires a priority level of attention? Please select 3 components and decide upon the priority by putting them to the place number 1, 2, or 3. Early detection and early notification. Detection. So the first, second, and the third priority. Please select among of those. It doesn't work, people are saying. And so the voting is not working. Just like on the Eurovision, the webpage is off. Everybody decided to use it. It's an enormous activity. We can't hold this vote. But you are able to vote for the first one, right? Yes, yes. And right now, technicians are telling us we will be able to fix the question number 4. So let's revote, or 10 seconds. So what is that? Is it the last question, or or you have voted for it already. So that the place number 1, and then the early detection and information. And then the voting is continuing, but still the place number 1 does not change 60 point. It's early detection and notification, the patient pathways between the facilities and units. And then the coordination between the services providers. And a few seconds more. Yeah, but it's clear, the general picture. And thank you so much for letting us know. Thank you, thank you, thank you. So the place number 1 and 2 are going neck and neck. And the voting is off. And what are we receiving in this space, and what are we else going to have the question number 4, and then when we've modeled the situation, and then when you had to answer to your opinion, what you thought of needed to be done in case of a similar situation, and what is the organizational solution has to be the first in line. 62% of people among the present or online, they need to have the unified patient pathways and to set the responsible people, and then to have the coordination. It's a lot of from other answers, so it's by far the most chosen answers. And then to have the electronic data exchange. And then you also see the results of in this questionnaire. So thank you so much, dearest of friends. And this is, in any case, it's a topic for a possible tomorrow's discussions, and this is it so far, so it's not going in vain. And then we will be continuing with the set of presentation that we had for you today.
So when we speak about continuum of care, we mean that the person shall not be lost between the stages, between the identification of diagnostics till treatment, and namely the funding is stipulating whether the stages will work as a unified system. And Svetlana Dudnik, MD, PhD, Director of the Department of Strategy for Universal Health Coverage at the National Health Service of Ukraine, will speak about this. Ms. Svetlana, the floor is yours. Greetings. Today, we are going to have a look at the continuum of medical care for TB patients, HIV patients, as well as those with hepatitis and substance use disorders from the viewpoint of funding. But I would like actually to put apart two things. Funding is an important tool for sure, but not every problem or challenge along the pathway is the funding problem. It's very important to understand what the challenge is all about, why we are losing a patient to follow up. Is this related to models of funding, or maybe that's the issue related to some other things, like, for example, bad interaction between the healthcare institutions, a lack of proper access to the network, and other things. We can keep on enumerating them, but I would like to start saying that continuum of care is not a responsibility of just one institution. On the screen, you can see, so to say, a visualization where we can have a look at all the key participants involved into ensuring the proper pathway of a patient. So this would be the state policy development, creating of appropriate projects, establishment of institutions, implementing public health measures, proper surveillance, issues pertaining to providers of healthcare. And the National Health Service within this system has got its own place in this system, dealing with strategic procurement and also ensuring procurement of the medical services that are needed for the patients. Using the state money, using the state budget. But in the center of the system, we see a patient. And actually, it all depends whether all the stakeholders interact with one another properly to provide proper care to the patient. I would like to highlight the role of local self-government, of managers of healthcare institutions, because at the local level, people better know their own local needs, and also they better know all the barriers which are out there, and it's clear that it's possible to arrange a network and make this network accessible. Speaking about continuum of care, the pathway plays an important role, whatever the pathology is. And I would like to highlight one thing. It's not funding that dictates the clinical pathway, but namely the clinical pathway stipulates for the need in medical services that later on will be in the basis of the program of the medical guarantees. Then the state is procuring the services, and then the services are provided by the providers of the medical services. So the clinical pathway is the basis for later on to have an appropriate funding model developed. So, when we say that, for example, within the framework of the medical guarantees program, certain clinical element is not taken into account, certain services are not being paid for, we need to understand that then we might have a problem within the clinical pathway or in protocols and standards, because I'd like to highlight that pathway standard protocols and guidelines are in the basis of the packages of the National Health Service. Speaking about the key stages of pathway of patients with TB, HIV, those getting substitution maintenance therapy, or B and C hepatitis, well, these stages can be presented generally. This is not a very profound clinical pathway, but we are just singling out key 4 stages. First of all, identification, then diagnostics, treatment, and follow-up. Why do we need this visualization? For us to be able to see at once that, for example, there's no single package within the medical guarantees program that would take care just of patients with certain pathology. So, we will go back to the issue of these packages of medical guarantees. So, we start with the primary health care to identify a disease. Identification of such disease can take place at the outpatient level. There's an outpatient package, as well as other packages. This can also happen in the inpatient setting. You know, there's this variety of pathways that patients with this pathology might have. Then diagnostics, there's the list of packages. I'm not going to enumerate them. Treatment, also there are some specific packages. There are packages that are more general, for example, the surgical care, therapeutic package, and the follow-up stage. This one brings the patient to the primary medical level or the outpatient package. What's important in this visualization? We have to understand that a patient shall not be oriented here just at the medical guarantees package, because I remind you, it's based on clinical standards, guidelines, and for a patient, for this care to be really continuous, it's important that the patient is really following the pathway, for them to understand what kind of pathway they have, where to go next, and then all the members, participants of this very pathway will ensure smooth transitions for the patients not to be lost to follow up. So this would be a more detailed visualization of what a patient might come with at the key stages of the pathway. For example, patient might resort to certain package with some complaints. Usually this would be the outpatient package. Maybe that's the screening or preventative examination. Diagnostics also includes certain scope, and there can be various scenarios. You can see it on the screen. So what I'd like to mention by this slide, the continuous medical care would be kind of a cycle, not a linear pathway. And it can also be changing depending on the clinical manifestations and situation in general. So if now we discuss certain packages that are aimed at treating TB, diagnostics and treatment, that's a separate package of people with HIV, and separately this would be people who use opioids or are covered with the opioid substitution therapy. Here you can see the expenditures for 2026 and number of services providers that signed contracts for 2026. The general scope of funding is 1.7 billion hryvnias, but now, well, the state is paying for specialized medical care packages, those that are aimed at certain therapeutic areas. And we have a range of packages, and later on I will exemplify as regards treating patients with hepatitis B and C. So the whole spectrum of the packages are going to be presented to you, using which patients can get proper care. And now we are going to have a look at a few slides to have a look at TB package within the primary health care level. And as of now, we've implemented the follow-up. That's package number 20. Those who work with this know that that's the number of this very package. There's diagnostics, treatment, and follow-up of TB cases, and then separately HIV, OSD, and hepatitis. What can we see on this slide? We were trying to show the number of unique patients in every region of Ukraine per 100,000 people. So please don't get confused with incidence, prevalence. No, this is yet another indicator that is based on the information from the electronic healthcare system, based on the data as of the first half of 2026. You can see the number of active declarations in the table. You can see the number of services providers that are providing this type of care. And you can have a look at the number of unique patients that are being followed up within this first 6 months within the primary health care level per 100,000 population. So you can see that the number of patients is quite not homogeneous. So we see regional differentiation. The reasons for such regional differentiation, well, we need to investigate them further. If we have a look at package number 20, and that's namely that very package that was created for the sake of follow-up and treatment of patients with TB. We see our network that's there in Ukraine, and that follows the strategy of TB combating. So we see number of unique patients, again, per 100,000 of population, in compliance with the number of active declarations. Again, it's clear that active declarations can be in this or registered in this or that region, but patients migrated because the one and the same patient can be reflected in two regions because they can be registered in one region but get treatment in the other. But still, this is the visualization that gives us general understanding of what's happening. And the same picture we can see on patients with HIV. We can see Odessa region, Dnipro region, and I believe that's Mykolaiv region here. So then, if we have a look at OST, then the appropriate figures are here. I'm not going to mention them. You can see them on the slides. So, all these indicators, all these figures, they require more profound analysis. Why we have these kinds of concentrations? If we have such concentrations, it becomes clear that certain load is present there on the providers of healthcare services. It's not homogeneous. So we have to understand, with this concentration being evident, we need to ensure provision of medical care to these patients. Then a separate example for you presented here in order to understand to what extent pathway of patient and continuum of care cannot be covered in one package. So, patients with hepatitis B and C, we see and we know that there's no separate package dedicated to this condition, but these patients can get medical assistance within several packages. This is outpatient package, primary healthcare therapeutic package, surgical package, and this is a package for treating people with OST and etc. I'm not going to enumerate it all. You can have a look at the number of healthcare institutions, and here I would like to highlight that this is the data from 2025. I really wanted to show you more complete data, what we have in the healthcare system of Ukraine, and also separately the number of patients who resorted for help. The number of patients would be the unique patients, but these are patients who had the underlying diagnosis or comorbidity, hepatitis B or C. So we know how many comorbidities actually these patients have and to what extent they need medical assistance. So, we need to understand that a patient is not moving along in between packages. They have to move along the clinical pathway. A patient doesn't need to know all the architecture of the program of medical guarantees in order to get medical assistance. So, the program of medical guarantees in the process of provision of assistance can provide medical services to this patient using the state budget, using certain packages, and certain stages of the clinical pathway can be relying on several packages. So for patient, it's important that there is a clinical pathway of getting medical assistance. But for National Health Service, it's important that the clinical pathways are created in a clear-cut manner, for there to be protocols and standards that are updated, that would include all the clinical components and versatile mechanisms of procurement of medical services can be used here. What does it mean for the providers? That there are various stages of provision of medical care. There shall also be an appropriate communication between all the stakeholders and all the healthcare institutions. So, now we can say that funding of a service would be just one of the conditions of continuous provision of care, where we can see gaps. Now you can see that the pathway can be interrupted. Patient might fail to reach diagnostics, or patient might fail to get to follow-up stage. So, I have a question at once to you. Tell us, please, then, that might be the problem of funding? No, not really. Most frequently, we can mention such reasons as organizational, meaning the service is there, but there is no transition for the patient for them to move forward, because organizationally, it's not ensured in what way the transition from one stage to the other is going to happen. Then, maybe the coordination role is not specified. Who is going to refer the patient and who is going to accept them at the next stage? Then some problems with the information, because the providers might not have the complete information. Not always the information is updated. Not always in the regions they've got clear-cut pathways, and sometimes the patients are not informed properly to understand that the state is ensuring that they're proceeding with the pathway. So, funding of a service does not equal coordination of a pathway. And again, the financial tool is quite a powerful tool, but it does not replace the provision of medical assistance. So, another example might be the following. For example, even if we have a clinical pathway, we can see this in the ISOS system when a patient is not transiting between the stages, but we can see that a patient got to the first stage and they don't show up, for example, at the third stage. Somehow they skip the stages, but this way the services are very fragmented. An important conclusion here would be that continuous pathway requires clear-cut coordination. And a huge role, and I would like to go back to the local government and managers of healthcare institutions, the financial mechanism on its own. And I mentioned this already and highlighted that this is quite a powerful tool, but its resources are limited. Not in terms of tariff. The financial mechanism can create certain stimuli, pay for outpatient services, pay for some outpatient as well as inpatient services. Also, there are some additional motivational coefficients, but funding on its own cannot create and ensure adherence to the pathway. It cannot substitute for managerial decision, as well as other factors. So, what's important? It's important to at first stipulate what is the problem, why the patient is being lost along the pathway, and then select a tool to use to mend this situation, and then this tool shall be improved. I would like to go back to the previous slides where I've presented the map with the number of unique patients. Ukraine always had certain differentiation, speaking about incidence and prevalence in various regions, we might see some specific peculiarities, some reasons why patients are not transiting properly. This brings us back to the question of the role of communities and local governments in supporting patients along the pathways. And again, if we see a gap, for example, the medical care is not continuous and the patient is lost, is that the problem of funding? No, not always. And that's not the problem of the need to create new financial mechanisms. That's the problem of managerial decision, comprehensive approach to medical and healthcare services. So at first we need to identify the reason of this gap and only then try bridging the gap and select an appropriate tool for that purpose. The next steps I'd like to mention about the steps taken by the National Health Service. So in order to ensure the continuous pathway of a patient, the National Health Service analyzes data on patients, including patients with TB, hepatitis, substance use disorders, and HIV. Then we have a look at the stages and in what manner a patient was proceeding from one stage to the other along their pathway. If we see that, for example, there's certain gap, we analyze it to understand what was the reason of a patient dropping out of the pathway. If the funding is the reason, it means we need to reconsider approaches to reimbursement, models, tariffs, etc. Then, if we identify that funding is not the reason, for sure we communicate with our colleagues, with Ministry of Health or MOH, PHC or Public Health Center. But we need some other, more profound solutions sometimes, rather than just communicating with the mentioned institutions. What are our future plans? Well, in the first place, to ensure all the payments for the healthcare services related to the identified therapeutic areas, where the financial mechanism adds to ensuring continuity of care. For sure, we will be using appropriate stimuli, and we are oriented at the following, where the financial mechanism can influence the results of the treatment. We are ready to consider options as regards various stimuli oriented at achieving the best result possible. And what I wanted to finalize my presentation with, in order to improve the continuity of care provision to patients, we need to speak not just about funding the medical services, but we need to clearly identify and reconsider and clearly identify roles and ways of interaction of all the members of the process, because the best results for the patients are actually there in the pathway, and this stipulates intersectoral interaction of all the stakeholders. And again, I come back and I highlight the huge role of owners, local communities, local authorities. Thank you. Ms. Svetlana, thank you so much in the first place for interesting presentation and for your patience. So many announcements of air raid alert and the lights were shutting off, but you continued. That deserves a round of applause. We have a few questions. Is that okay if you ask those? So, a question. Does the current funding structure sufficiently incentivizes not just only the provision of individual services, but also coordination between primary care, specialized services, inpatient facilities, and substitution maintenance therapy? Thank Thank you for this question. I would like to actually split it into two parts: issues of funding and issues of interaction between providers. As I've mentioned, the medical guarantees program in general covers all the necessary services using the state budget. Patient can get this assistance following various packages at various levels. This can be the specialized level, the primary level. This might be various providers, but if a patient fails to stick to the pathway, this can distort the continuity of care. So the National Health Service reconsiders the approaches, and we are ready to reconsider the funding mechanisms, but if the reason lies in the organizational plane, then creating a new package or raising the tariff would not help. Thank you. I got it. So the second question from our audience. Tell us, in the context of war, certain people are at the highest risk of falling out of the continuous care pathway, in particular those with comorbidities like TB, HIV, hepatitis, or substance use disorders. So what mechanisms can reduce these losses? Well, for sure, the war influences the continuity of care. For example, if that's internal migration, it's easier for us to influence it. But we also see a situation when people move abroad and then they are lost to continuous care pathway. They might be getting certain services with delay if they come back. If to have a look at today's situation, I would actually say this. What's important? The activities of the local communities and local authorities. They have to dynamically assess the needs in the region. They need to create an adequate network. They have to ensure a proper interaction between the providers. And I would like to highlight that we need more data. You were asking about this in your survey. We see, for example, that a patient, speaking about data, we see when patient got certain service, whether they transited to the next stage or not, we see certain things. But we need to be thinking about actually developing this functionality even further to understand why we have this falling out and when they're coming back and why. This will help a lot.
Oh, thank you so much. There's two more questions and to that note from our viewers. So the system-wide informing of the population about free of charge services and diagnostics and treatment and the support for HIV, TB, and viral hepatitis and dependencies or addictions can aid to early detection of cases and the reduction of disruption and continuity of care. It's clear that NHSU right now cannot provide for the financing on the info campaign. Do you think it's effective for the regions to conduct those info campaign, and then can this informing can actually improve the situation? And of course, I think that the info campaigns has to go to as in volume sufficient. There have to be present, and then let me give a reflection regarding the NHSU that we can provide for National Health Service of Ukraine within our capacity. We are always open for communication, and I think that more actively than we are, I don't know other state institutions that communicates this much. We are always presenting program for medical guarantees. We are always saying that how to the doctors and also to the patients. We are meeting with the public organizations. We are seeing about the patient pathways and then the amount of services, and then including care where you can get this service, and then also we do have dashboards. And let me get back to the regional information systems, and then why are they effective? and then the requirements and everything else. And then as far as we've seen the differentiation that regarding the number of patients, and so in the regions, it's known much better. But let me announce something else. The info campaign, it's a great story, but like who's doing the info campaigns in the region, they need to see that this is just the tip of the iceberg. Why? Because if you did this info campaign, this means that in your region, the system for services provision, after that, they have to provide for accessibility, so that this is not a campaign for a campaign itself. This have to be so that the patient understands that they've asked a question, and then they understand that they need to get to a doctor, and then they receive any other given treatment, and so on and so forth. We know that this campaign for a campaign, and then we would just like for it to be, as you mentioned. Dear Svetlana, what is needed to be changed in how the services are organized, payment for packages of services to provide for a real transfer from the quote-unquote coverage of the services or for an interrupted provision of services? To a continuous management of cases on all the stages of care. I wouldn't really say about the unofficial funding, because funding is there, and then it's not in the funding. The reason is you need to review the whole system of care provision. And so I would just like to say, for us to get rid of the thing that the patient is out of the patient pathway, you just need to make an analysis. So how is this supposed to happen? So that mechanisms are the tool. First of all, we need to have a amount of data. We need to analyze them. We need to finalize the reason where, when the patient's going out, and then there's supposed to be a responsible person or the developed or an improved algorithm or the instrument. Then the instrument is needed for the regional specifics and everything else. And about the electronic health system I mentioned before, the moment just to see more, but this is not the most important thing. The interaction, intersectoral cooperation, and also we understand that right now we have a lot of integrated services. And so here the matter is to, once again, in the patient pathways, they're supposed to be specific. They're supposed to be foreseeing all the options where the patient can see, lead to, and other things, so that the doctors in their practice, they would need to know where to direct and divert the patient. If everything will be revised in the organizational moments to which the affordability of care or accessibility to care, depending on which sector you're looking for, they have to be minimized. Regarding National Health Service of Ukraine, I just wanted to mention that, yet again, the reason is not funding, but for the next year, for example, we have and both of the inpatient treatment and also management for patient in the primary care. And this is more so differentiated. And then regarding the inpatient treatment and outpatient treatment, we want to implement this stimulating coefficient for patients to be transferred within our responsibility to as much as possible. So it's clear. Thank you so much for that, for the presentation, and then for answers to questions. And then will you be here tomorrow? Not planning to, but yeah, thank you so much. But thank you so much for giving us the floor, and you will be given to. And thank you so much. And then, dearest of friends, as I mentioned before, our technical difficulties during the first panel discussion was that our speakers has shown me on the tablet that there is no question, and then it is giving me those questions that have been absent before. So let's try to give it an answer if our participants have not yet left us, but I think that they're still here. So I'd like to welcome to the floor Yana Terleyeva, Larissa Hetman, Irina Skripka, and Irina Ivanchuk. Yana, Larissa, and wherever is easier for you to sit, please select places openly. I guess Irina is not here. And the chairs we have for even more people, but yeah. So then, thank you so much for staying here. And also, here it says the question is to whom, so I will be addressing them to whom it is, but if you have something to add, then please use the microphone accordingly to Jan. What the first question goes, in your opinion, what is causing this small percentage, 11% on the secondary stage? I think it's concerning my presentation. We represented the number that only 11% from the ones who that require testing for the latent TB infection have actually went for testing for presence of that, using the test capacity capability that are accessible, so that testing with the Mantoux or quantiferon test or novel skin test. And so here it's worth mentioning that traditionally for many years on the highest level of testing, the testing are more so for to use traditional for a national program of TB categories, such as people who are in contact HIV infected, because those are the categories that we're working with for many years. But in the past 2 years, what we have is the novel clinical groups that we also have to test for the presence of TB infection. And then there goes for people that needs a organ transplant, people who are using a hemodialysis, have a human necrosis factor, or have these conditions called silicosis. And then what we're seeing is the overall decrease of coverage. And because of those clinical groups, what can we connect with? Those are novel groups that have just appeared national standards, and then the program needs to a bit of a time to build the patient pathways for people to know, that increase the awareness of medics. And so we would think that this is just in the few of the issues. This is one of the things that in a significant way they widen the access to modern technology for TB diagnostics in the past few years. And then a few years ago, we have the arsenal of tests for the TB infection to be tested altogether. The other thing that this is connected with, that I voiced in my presentation, that the people are not regarding prevention as something important. And when we are speaking of tuberculosis, the first thing, even when medical experts are saying that prevention in TB, wash your hands, ventilate your rooms, and yada yada. But in the best case scenario, they would probably remember the BCG vaccine that is staying an important element on the TB prevention system, and why and what is important for treatment and awareness of prevention will be serious enough, and for them to know that lives and livelihoods of people are standing behind it. And what we are seeing within our research and observation, this is the most important barriers, and the awareness of health workers, because unfortunately, so far what we are seeing is that there are some disruptions in the system. And so when, for example, a transplantologist can prepare the preparation of the person for transportation, not always in their protocols that they have to test if they have a TB infection, even if they go in to have an organ transplant. Therefore, there are cases. We know about these issues, and then we've shown that in 6 months of this year, a significant progress, almost 60%, but still we are very ambitious program on TB, and we are putting an objective to have at least during war 95%. Then a target is 100. Those 11% of tested for TB, those is from the general population or among the key groups. So it's an important, those Soviet programs of TB combating, they were built on the mass ungrounded screenings for our general population, general pediatric population for TB, and then in TB, non-targeted massive screenings, not for TB infection, not for anything else, have not shown their effectiveness. We've mentioned it a lot of times about this. This is not just the TB program. This is the data acquired in the world. This is not effective. When we're speaking about this 11% for the past years, we are just mentioning testing of those among whom this has to be tested. So evidence-based, based on the criteria, so WHO adapted and recreated to the context of our country. And so the people who are in contact with the people having TB, HIV, and then people who are being treated with the TNF alpha, and then silicosis, and then I think I missed somebody. Tell me, there's a lot of pediatricians here, or TB doctors. Oh, and organ transplant. Yes, so that coverage and is among those groups of patients, unfortunately, was not sufficient. Okay. And then the request is to answer for all of the speakers. And do you see a change in paradigm from stigma to being tolerant from health workers, from health facilities, especially in the primary care? And then with the social conditions and the representatives of the key groups. So what do you have to say about this? Let me start off from here. The best medication from stigma is knowledge. And they are concerning the independently if this is the representative of the key target group, not key target group, and the knowledge that are in terms of the transfer or contact methods, or how does it spread, and then how to consult the issue of how to moderate the issue in terms of the if somebody's compliant with treatment. So we remember those times when, on the example of the post-exposure prophylaxis, or PEP, which is the prevention after the possible risk of being infected, which is 72 hours when you can still prevent HIV infection at the possible risk, among the medical community, to inform, to reduce the stigma on providing those services. And this is really had worked. And then and you need to work with that constantly. Therefore, there is a change in workforce, and people are changing, migration. This is the continuous question that you have to work with. Also on the local levels, training programs, and then other things, notification, info campaigns. But it has to go through knowledge. Does the word slow this process down? I guess it creates a different environment. I can't say that it slows it down, it just creates a different set of conditions. Do you mean the priority that is given to other matters like on this topic or not? Regarding stigma, if it's there, it's gonna stay there. Independently, the determinants of stigma can be reinforced, get weaker, but I think it's independent from that. Thank you so much, Indiana. I would like to add a few words here because it's very important stresses done by Larissa, and I would just wanted to show the matter of stigma more so through the TB. Let's remember, where did the stigma come from? The stigma came from the times when TB was de facto an untreatable condition. There was no medication, there was no capacity that we have right now. This is the term number one. And so that people, in a lot of ways, they were afraid of TB. And of course, they were afraid of TB, they wanted to be isolated, distance themselves, and so the health system also has been working in a way that the person who has detected TB, for the whole treatment site to be closed, imprisoned into anti-TB facility before they get better. But a lot of time has went, 30 years has went from there. And TB is treatable. TB, for the most number of patients, it's safe to be at home. And then after the few times of treatment, also to get treated on the ambulatory stage of care. But the issue here is that society is not only aware, knowledgeable about that. And so this misunderstanding of why Larissa is saying that the knowledge first, our weapon is knowledge. And we need to get to the point that the people with the medical systems facing and the society, an info campaign is being brought within the TB combating months, and then throughout the year intensivity is going down, and accordingly, and then they're not reaching. And if you're asking if the war has influenced somehow, but in the conditions of war, to overcome and to fill the information field or environment with solving such an important topic is very, very hard. Our attention, what are the consequences of showing? If everybody's alive, what is the health facility, support for the army, and then all of the thoughts are more so around it. But this info campaign that you're mentioning right now, but who has to be the front line? Is it the government? What is acting? But I think that right now the conduits of those modern knowledge has to be every single one of that. Which factors are we trying to base upon in the government and state institution? We have a strong arsenal, which is Center for Disease Control and Prevention, and then the patient organization, communities, opinion leaders, and then and the society has merged together that if a person faced with this issue was this, then when the Ukrainian foreman has died from social media. And then this is the first time when I saw that society tolerated and everybody treated with support and with understanding. But unfortunately, so in reality, what we're seeing that a completely different picture when those people are not being let to work or getting fired, not getting to the school, and then more so they're trying to get outside of community. This is unfortunately the reality. There, unfortunately, if everybody will be understanding where does they and not to be tolerant. We have to be human-centered, be good and kind and with compassion, because this is a trunk suit of our nation. We have to get back to that and with our faces to the people who just need to that are having it hard. Thank you so much. I agree with Irina. Do you have anything to add? I do agree with what Isa had mentioned about the knowledge, and then I guess I'll add that apart from knowledge, this is experience and practical skills. Quite recently, viral hepatitis was also marginalized issue. And then this is the issue of some of the groups and the general groups of population, people that they've never been infected by viral hepatitis. So the opinion was among others as well. And then the experience of the wider circles of doctors, especially general practice and family doctors, or not just infectious diseases, but also narcologists, pediatricians, and then other specialty has shown us that this condition is good for many people, and this doesn't mean the marginalized groups. And then the treatment of that is different. Stigma has decreased, and an ability to use the same screening practices or treatment practices and their experience, and then not just for a communicable disease doctor, they've changed the treatment of health community to the patients with viral hepatitis. Thank you so much. Before there is a question to you, Rita, was which legal documents you recommend registration and reporting confirmed cases of viral hepatitis? This is the order 905 is a confirmation of, and also Ministry of Health has an order. And then if patient in any way, because of stigma, fears, and whatnot, I guess this is a widespread thing, they don't want to receive treatment on TB and the family doctor, where can they find it after the September 1st of 2026? Is something going to happen from that time? Or so what will happen in reality? Right now, as we mentioned before, the approaches have changed, and people in the vast majority can get treated in TB on ambulatory level of care. And so what we did is the significant step forward so that there is a movement to the ambulatory provision of care. It's more human-centered. And then the vision is that the patient has not just to be treated in an ambulatory stage, but to receive care of their family doctor. And that change had happened in national idea, and the curriculum administrators primary network has to be ready to adapt to change the pathway, SOPs, and then in the curriculum administrators. And we understand that the family doctor are worried, getting ready, and then together with that, we also understand that this is the right of the patient, because a family doctor knows best what specifics does he have. They know what kind of diseases, conditions that the person is facing, what other medication they're getting. And then because they might be going in the line, not in the line, all the information is coming to the family doctor. They know everything. And then we understand that there are issues connected with the fact that we are facing this in reality when the patient doesn't want to get treatment from his family doctor. They're afraid that it's going to be announced, or they trust more to pediatrician that they think is much more specialist qualified. And they have emotional contact, and the patient wants to receive care in another place. And so one of the principles that are provided in the country that the care is oriented to the patient. And if the patient will want to receive treatment in pediatrician, this right will be provided. They are righteously doing so. For that, we have this multidisciplinary approach when they're trying to understand, like, what is the better thing for the patient. This is why this option will be foreseen. And right now, there are a few models apart from the family doctor, pediatrician. The patient can also get the support from the social worker, or to receive the support during treatment using video dot or video supported technology for Viber phone. It's all possible to have a contact with the patient and to get his pathway forward for getting better. So I think the patient today will find the opportunities that can help him or her, and they have the full right to get this. And an interesting question, and I'll ask to. So everything around stigma, everything around non-tolerant responses, we need to work with that. This is obvious. The reported speeches, then how differently state institution and private institution actually perceive this patient. Is there control and analysis of behavioral doctor in terms of what they're doing there? I don't know if you have the answers, and then the control of you when you're controlling, and then there's something is changed. But we are trying to, then we have to reach and then to explain what is this stigmatizing or not tolerable or behavior that's not tolerant to other. I mean, the person understands that what means under the stigmatizing behavior, then they change their practice, really. And then the sizes are there, and then we had 2 researches conducted, and then 100% live and network, the level of stigma measurement among the society, medical workers, and then their specific measurement. And then we conducted the repeated research that are showing that those actions that we are conducting, info campaigns, forums like this, and then the video institution, they're acting, the level of stigma is decreasing, but unfortunately it's still staying one of the key barriers. So I would have went to that you need to get back to the explanation upon explanation, awareness raising upon awareness raising. So you need to make such a snapshot of information through research, assessment, or encounters with the patient that have the capacity, which is the hotline national.
Пацієнтських організацій, які
Patient organization, National Health Service of Ukraine, they can protect the rights of this patient. And those instruments are also available. Thank you so much. Do you have anything to add, dear colleagues? Because on that we are run out of questions. I would really like to add here, Larissa has been speaking, regarding the last question, that there are instruments where patients can reach out to somebody for that. And then you need to inform about issues? Is it like a resource, or this is patient organization? This is the advocates, not unions per se, but like paralegal support or hotlines. So if you inform that there is an issue and then it's acquired on the level of health facility, then of course there is a response to that. And if we are to refer to about the snapshot and health facilities that are right now at that situation that are providing services on HIV, then those facilities are privately owned, municipally owned, and then this is the highly specialized centers and primary care doctors. And then from what we're seeing is that on the experience that we had so far or our interaction, significant changes in services there just doesn't exist. There is a standard of care. There is a protocols on how to provide those care within the standards, but the terms of stigma and tolerance and discrimination, they're outside of official documents so far. Not comment, but a request. You are an ambassador of that. I was waiting for this, and I think that for our personalities, we'll be able to move this more. And if you would have went out with an open message that stigma is not supposed to be there in this society, I think that you would brought your big increased. Thank you so much for trust. For me, this is valuable. And then I'm fighting stigma, but on women, domestic violence, gender-based violence. So let me tell you the following. I wouldn't want it to do that. And so in such a lively discussion, when you're integrating, listening to, and of course I'm far away from the topic today, I'm getting closer. There is a wish to share with the audience. But as the person with the big audience and influence, I would like to highlight that today information has to be presented and fact-checked, precise, easy to understand language and wording as addressed as possible. So in the flow of everything the person is bombarded with on daily basis and this clickable attention span. So I personally, I wanted to write about this, then I would be reaching out to Natalia, to Gunta, I will be reaching out to with the facts so that you would give me a information that I know that I have the wonderful opportunity of one big post to reach out the people. Then yes, we are putting in front of ourselves objective. If you're able to reach out to something, and then because I'm a mother, I know about the BCG and that's it. That we didn't do in the first days, so they're saying they don't have in 2014. It wasn't there. But then we did it, and so yeah, connections, and I know people, and so and this I know. Apart from that, we did the BCG vaccination, and so if I was explained of this in a clear way, in the biggest trap, Yana, which is the people who know something in social media, this is what I afraid the most. Daily, so many pieces of advice, and you don't know where to save those women, because I'm usually dealing with mental health disorders and for women, and you don't know how to save them. Therefore, I'm grateful for your trust. I promise that I'll take all of the information from the initial sources. I'm very much interested to share. I have a wonderful and big female audience, and they will have to know, and they have to know what kind of vaccination to do and what kind of preventative services or activities or something else has to be in every case of the way. So thank you so much for welcoming me here. For me, it was very useful. Thank you so much.
Дякуємо вам.
Thank you.
Будемо на цьому.
Thank you. And I believe we are going to say goodbye for today. Actually, today we had a very saturated day. We were really productive, and there's plenty of food for thought before tomorrow. Well, speaking about tomorrow, don't be late, but you're great. Even after this difficult night, you were here in a timely manner. You will start with coffee. The official beginning is at 10. And we are going to speak about organizing integrated, person-centered care, TB, HIV, viral hepatitis, substance use disorders, and mental health, from prevention to treatment and support. We sincerely thank all the speakers, moderators, partners, and participants for your work, candid discussions, and commitment. Thank you to those who joined us in person. I believe tomorrow is going to be even more interested. We strongly hope we will have a good sleep this night. Thank you for being here regardless of anything. Thank you for dealing with human health. Thank you so much, and see you tomorrow. See you tomorrow, friends.